have Dr. Muhammad
Yeah.
with you, so
Yeah,
don't
I
worry
will
about
start.
me.
Okay.
Dr. Muhammad, good to see you.
يسعد
Can you hear
مساك
us,
يا
Dr.
غالي.
Muhammad? Hala habibi, hala. Okay, so everything is working? The sound,
Yes.
the camera, the everything, yeah? Dr. Mazen, we have 2 minutes.
Yes.
Dr. Abdullah, how are things in Lebanon, my friend?
Difficult times, hard times.
Well, I'm sure you'll go through these difficult times.
Inshallah.
You've been through, be fine.
What's going? Muhammad, what is this noise here?
بيكون حدا دكتور عنده موبايل من جنب الميكروفون.
Muhammad, we're gonna start in 1 minute, huh?
Yes.
Okay.
هينا عم ندخل الناس. They are هلا 50.
Okay. Dr. Mazen, تفضل.
Okay.
It's time. تفضل, Dr. Mazen.
Good evening, everyone. It's my pleasure to share this activity. I'm Dr. Mazen El-Zibde, the president of the Royal College Representative Committee in Jordan. There will be Dr. Muhammad Al-Madani, the president of the Jordanian Society of Obstetricians and Gynecologists, as well Dr. Maher Ma'aita is the chairman of the scientific committee in our society. So we are going to have a scientific webinar, which is part of our series. As you know, my colleagues, we have been doing this series since April this year, and it will continue till mid of October. So this is the 8th in our series. And tonight we are going to have a webinar. The title of it is Obstetric Emergencies. As you know, obstetric emergencies are one of the major events, and every one of us has to be prepared. And not only prepared, we have to have all the facilities and the expertise to deal with it. I'm glad that we are going to have first speaker with us, Professor Laura McGee. Professor Laura McGee is general obstetric internist, internal medicine and clinical pharmacology at the Royal College from Canada, and fellow of Yondam Royal College of Obstetricians and Gynecologists in UK. She has joined King's College London, UK, as a professor of women's health, following consultant post at St. George's Hospital, University of London, and the Universities of British Columbia and Toronto University in Canada. Professor Laura's research is focused on pregnancy hypertension, particularly antihypertensive therapy. She is president of the International Society for the Study of Hypertension in Pregnancy and chair of Maternal Medicine Clinical Study Group of the Royal College of Obstetricians and Gynecologists in London. Dr. Laura, I know her for the last 20 years. We have done some research together, and I'm glad that she has time to offer from her experience in this webinar. Please, Professor Laura, the floor is yours.
Thank you. Can you see my slides?
Yes.
Perfect. Let me just There we go. Great. I'm just going to minimize the grid so I can see my slides. So first, thank you so much for your kind invitation to join you. It's an honor. And of course, to speak about my favorite topic, preeclampsia and eclampsia. Now, just as a disclosure, I have no commercial conflicts of interest. I was the principal investigator of the CHIPS trial, Control of Hypertension in Pregnancy trial, and so I call myself a recovered, less tight controller of pregnancy hypertension. So just to highlight the main points I'd like to make in the talk, hopefully I will convince you of their merit, and then we'll sum up at the end. I'd like to focus on three aspects of preeclampsia. First of all, its definition, that it should be defined using the broad international society definition that better identifies women and babies at risk of adverse outcomes. That 2, antihypertensive therapy should be used to prevent severe hypertension and definitely treat it when it occurs. And that the risk of severe hypertension is independent of the risk of preeclampsia. So these are both important parallel considerations. And third, that around timing of birth, so that the term severe preeclampsia should not be used, as the disease is unpredictable, as we all know, and the term doesn't help us decide on timing of birth. That expectant care should be considered at under 34 weeks for all types of pregnancy hypertension, at term, of course, for preeclampsia, even broadly defined, and in between there are some controversies, and we'll talk briefly about those. So let's talk about the definition first. So the traditional definition of preeclampsia is hypertension with new onset proteinuria at 20 weeks or more. The broad definition does not mandate proteinuria, of course, but allows as diagnostic other relevant features, so maternal symptoms, maternal signs, or abnormal laboratory tests, or fetal placental manifestations, the latter being a bit more controversial. Now, the ISSHP advocates this broad definition and specifically advocates inclusion of the fetal manifestations. Now, at the end of the day, however you define preeclampsia, it should identify women at increased risk of adverse outcomes. That's what we're talking about tonight. We're talking about getting the best outcome possible for mothers and babies. And that is the whole purpose of classification. So I just wanted to show you a couple of analyses that we did that have helped provide evidence for the use of the broad definition rather than the restrictive. So just to summarize in I think a bit more illustrative form, there are the various definitions of preeclampsia. Of course, traditional, which just has proteinuria and doesn't have the maternal symptoms, maternal signs listed here, lab tests, or uteroplacental dysfunction. The American College definition is broad and includes maternal features. The ISSHP definition has both maternal components, so you can see highlighted in green here a number of extra components that aren't in the ACOG definition, and then they're highlighted in green, and then the full ISSHP definition with maternal and fetal components includes in yellow here, so IUFD, fetal growth restriction, the definition of which includes Dopplers, abnormal Dopplers. And then the 2021 definition from the ISSHP is going to weave in angiogenic imbalance as well, and that's highlighted in red. So we looked at one of the Fetal Medicine Foundation data sets at 35 and 36 weeks. And I want to highlight this because, of course, we know that somewhere between 2/3 and 3/4 of preeclampsia occurs at term, even though we spend probably as much or more time talking about the preterm disease. And so we looked at the merits of defining preeclampsia in various ways among just over 15,000 singleton pregnancies. And you can see, of course, that if you add criteria for a definition, then the preeclampsia is going to become more common. So you have 1.8% with the traditional hypertension and proteinuria definition. And at term, it went all the way up to 3.3, so a substantial increase. So it remains to be proven whether labeling all those extra women as having preeclampsia will do anything more than create worry without an improvement in outcome. And I just wanted to highlight that of all the, the long list of maternal and fetal features in the broad definition, most commonly, other than proteinuria, you have platelet count under 100, AST or ALT above 40, and the abnormal angiogenic markers were very common. So what did we find? Well, we found actually that the ISSHP definition did very well. So if you look here in this table, we have as the columns the definitions of preeclampsia at the top, ACOG, ISSHP maternal, maternal fetal, and maternal fetal plus AI, standing for angiogenic imbalance. And then we have the outcomes here: severe maternal hypertension, major maternal morbidity, perinatal mortality, and major morbidity, mainly the complications of prematurity like NEC and RDS. Neonatal unit admission for more than 48 hours as a generic measure of sick, which Mazen and I used in the CHIPS trial, and birth weight under the 10th centile. And you can see if you move from left to right, and these are all detection rates, sensitivity, that it increases as you move from the traditional definition to the broad definition. So you're actually better able to pick up mothers here, and babies at increased risk of adverse outcomes. And the yellow p-values show where the definition is significantly better at a p less than 0.05 level with a traditional definition. Now that's about defining preeclampsia term. So what about the women with chronic or gestational hypertension who may progress to preeclampsia? Should we label them as preeclampsia and manage them as such using a broad definition? And so we looked at the CHIPS data set for this. And I'll just remind you, our main outcome measures were our primary outcome was a measure of death or illness. So pregnancy loss or high-level neonatal care for more than 48 hours. And our secondary outcomes included our secondary maternal outcome of serious maternal complications, which ended up being mainly blood transfusion. And what we found was that there were a lot more women who progressed to a broad definition, 48%, than a traditional definition, 29%. But the broad definition, again, was better able to identify moms and babies at risk. They have higher sensitivity, so here in like 60s to 70s, as opposed to 36 to 50. Lower specificities, of course, you can't have it all. So 53 to 65% versus 72 to 82, but similar or higher diagnostic odds ratios. And this is key because a diagnostic odds ratio is the ratio of the odds of the test being positive if the woman really does have preeclampsia, as opposed to the test being positive if she doesn't have the disease. And the addition of available fetal placental manifestations actually improved sensitivity. So in conclusion, looking at these data sets, a broad versus a traditional definition better defines the women who we're most interested in and the women who we want to talk about this evening. And that's whether you're talking about de novo preeclampsia or whether you're talking about women who have another hypertensive disorder that may progress to preeclampsia. And that the advantages of a broad definition are particularly true when uteroplacental dysfunction is incorporated, and that includes angiogenic imbalance. So our second point, antihypertensive therapy should be used to prevent severe hypertension and treat it when it occurs, and that the risk is independent of preeclampsia. So let me work on you for this point. So severe hypertension, I'm defining in this talk, because it's important that we're all talking about the same thing, as a blood pressure of greater than or equal to 160 systolic and or 110 diastolic, so pretty standard. I think we would all agree that prevention of a problem is much better than treatment of the problem. And just as a reminder, the CHIPS trial showed that we can pretty much have the incidence of severe hypertension if we control blood pressure when it occurs. And then this can be done by a very simple algorithm: a diastolic blood pressure aiming for 85, increase antihypertensives if it's more than 85, and decrease them if diastolic is 80 or less. So titrating it like a thermometer, you're adjusting the temperature of a room. And when we did that, we didn't end up with very low blood pressures. They were beautiful. They were 133/85, and that was in 93 sites in 15 countries. So it's very straightforward. And I wanted to emphasize that women with preeclampsia were frequent. Remember, 29% progression to the traditional definition, 48% progression to the broad. They stayed in their allocated group in the CHIPS trial. They delivered about 2 weeks after disease onset, which is what we would expect. And so it's very reasonable to apply the CHIPS trial results to this population of women. So first, we need to stop regarding severe hypertension as just a higher blood pressure. It's a, rather than an outcome worthy of avoidance. So this is a point that I want to emphasize. Sorry, I'm just going to, it's my husband calling me, of all people, sorry. So we did a secondary analysis of the CHIPS trial results. We used logistic regression to examine whether severe hypertension was associated with more adverse outcomes. And here's the unusual thing that we did that adds to our knowledge, I think, is that we adjusted for preeclampsia. So we said, okay, independently of preeclampsia, is severe hypertension a problem, or is it just a bigger blood pressure? And it was a problem in and of itself. So if we look here, we have the adjusted odds ratios, 95% confidence interval p-values. And we're going to look at the baby outcomes first. So the CHIPS primary outcome, which remember was death or illness, and birth weight less than the 10th centile. And what we see here is that severe hypertension significantly increased the risk of adverse perinatal outcome. And that was true even when we adjusted for preeclampsia. Now, we did it the other way around as well. We said, okay, what's the risk of preeclampsia? Because we all accept this is a surrogate marker. It's a problem for mothers and babies. And adjusted, sorry, just have to cut him off again. And then adjusted for severe hypertension. The preeclampsia was still significantly associated with the primary outcome. So then we have birth weight less than the 10th centile. And again, we see severe hypertension, even adjusted for preeclampsia, is independently associated with small babies. So now, is this also true of the mother? And it was. So now the CHIPS secondary outcome, the serious maternal complications, were not like a low, platelets of 135 or an AST of 43. These were mainly blood transfusions. And there were only 28 events. So while severe hypertension was associated with an increased risk of the secondary maternal outcome, adjusted for preeclampsia, we lost the significance. Preeclampsia was barely, just retained a statistical significance when adjusted for severe hypertension. I'm showing you birth at less than 34 weeks, but also just preterm birth in general also showed severe hypertension independent of preeclampsia is a risk factor for very and all preterm birth. So we need to stop regarding severe hypertension as just a higher blood pressure. It is an outcome worthy of avoidance. We need to start antihypertensive therapy, both to prevent severe hypertension, as I mentioned, but also continue oral therapy as a preferred route of administration. So we know that the WHO, the NICE guidelines, the Canadian guidelines are all now, all of the guidelines are recommending treatment for severe hypertension in pregnancy. And many of the guidelines, so WHO, NICE, Canadian guidelines, are all recommending non-severe hypertension treatment in line with CHIPS. Now, the WHO labels this recommendation as strong with very low quality of evidence, and that's because we don't have randomized controlled trials that take women in pregnancy with severe hypertension and randomize them to antihypertensive therapy or not. That would be unethical. So there's general agreement that this should be a strong recommendation. If we look at the randomized controlled trials, and this breakdown really hasn't changed in the last couple of years, we see that most of the evidence has nifedipine compared with either IV labetalol or IV hydralazine. This has been, these data have been subjected to a network meta-analysis in the British Journal of Clinical Pharmacology back in 2018. And at that point, we had 46 trials in the network meta-analysis. And the updated literature included 15 new trials, and importantly, many from low and middle income countries where the majority of women with the hypertensive disorders of pregnancy are dying. The parenteral administration was the rule other than for nifedipine, and I'm just going to highlight there was no oral labetalol in this network meta-analysis because this is a point to which I will return. The primary outcome was achievement of target blood pressure, although the target wasn't often specified. So 5 trials had under 160/110, with which I think we'd all agree. Under 150/100 gives you a bit more safety. That was in 7 trials, but the other 20 trials just didn't specify what they were aiming for. This is a network plot, and it just illustrates the bigger bubbles are the antihypertensives that were studied most frequently. And so nifedipine, labetalol, hydralazine, sometimes called dihydralazine, sometimes called hydralazine, with the darker lines representing the direct comparisons. The evidence wasn't too bad. It was moderate quality. And for the majority of the comparisons, there were no significant differences in target blood pressure achieved. And the target was achieved equally quickly. It was slightly better in terms of number of doses with nifedipine versus hydralazine, but very small, like 0.4 doses fewer. And labetalol versus hydralazine was associated with fewer palpitations, but nothing really overly exciting, which is good for us as a care community because it means we have choice. We have choice depending on what's in stock. We have choice depending on whether, for example, a woman has a history of significant asthma or she has migraine, and we're less enthusiastic about nifedipine. Choice is a good thing. What this network meta-analysis did, which I think is important, is they also did a trial sequential analysis to see whether there was we could have enough confidence that we'd accumulated enough evidence to say they're very similar. We can use either one of these in our clinical practice. And so the finding of a relative risk reduction of 10%, if such a difference existed, and they calculated this when it was a minimum of 5 trials, is the threshold that they used. And I think that's reasonable. Like if there's something smaller than 10%, that's probably not clinically relevant for us. And the important take-home messages here from these graphs is that the amount of evidence we have lies between this reasonable boundary. And so the conclusion was there's enough evidence to say PO nifedipine and IV labetalol are similar for severe hypertension, that IV hydralazine and IV labetalol are similar, but that there isn't enough evidence to conclude with reasonable certainty that IV hydralazine and oral nifedipine are similar. We're below this bottom red line here. I just wanted to mention just briefly that we have far less information, as I'm sure you know, about postpartum treatment of severe hypertension. And we just kind of have a smattering of comparisons, which I hope to illustrate in this grid here, with a methyl-dopa hydralazine, labetalol hydralazine, nifedipine hydralazine, and none of them found that blood pressure control was different between the trials. But you know, most of these trials are very small, right? 26, 82, 38 women. So we don't have much evidence, and it's quite reasonable, I think, to extrapolate our antenatal information to our postnatal, at least for now. I do want to acknowledge that in the trial of clonidine versus captopril, Neurona did find that clonidine was associated with better blood pressure control. But of course, clonidine is not advised during breastfeeding because of higher levels in milk. So it's not as helpful of result as one would wish for. Now, I said I'd return to this issue of oral labetalol. So could we manage severe hypertension with oral agents? So while, excuse me, uncontrolled severe hypertension is life-threatening, a controlled fall in blood pressure is advisable. In non-obstetric adult medicine, the goal is to stabilize the blood pressure, and that's to sort of see it coming down progressively, maybe 10% per hour, until the target blood pressure is achieved. And so for us, that's going to be under 160 over 110. And overly brisk falls in blood pressure associated with hydralazine have been related to increases in fetal distress, increases in cesarean, and lower 1-minute APGAR scores. Now, I suppose the key point is it's just unnecessary to drop the blood pressure that quickly. And so we do need to be concerned about how quickly we do it. So oral agents would be very appealing, right, with slower absorption, more gentle influences on blood pressure. And certainly the NICE guidelines since 2010 have been advocating oral labetalol. I might say with very little evidence, but I think they might be quite right anyway. So I'm going to show you this. So I wanted to highlight that we have 3 small trials, like 1982, 1983, and 2017, with 145 women. So very little evidence comparing oral labetalol to other agents, either methyl-dopa, hydralazine, or oral nifedipine. And then there's been quite an influential guideline implementation study in Yorkshire, in which the Yorkshire guidelines used 200 milligrams of oral labetalol to treat severe hypertension. And these data together suggested that oral labetalol could be successful in at least half of patients. You know, that could be quite useful if you're in the, you're seeing a woman in the office, her blood pressure is really quite high, and you want to give her something to start taking the edge off it as you're moving her to hospital, or you're getting her stabilized in your triage area. But the Genuity Health Project's oral antihypertensive trial really tested oral labetalol. And this was a randomized controlled trial of women with severe hypertension in 2 sites in India. And so there were 894 women randomized, and they were randomized to either oral nifedipine, that was the PA tablet, oral labetalol, 200 milligrams, or 1 gram of methyl-dopa. And the nifedipine or the labetalol could be repeated hourly for a total of 3 doses, whereas the methyl-dopa was just the 1 dose, because we weren't sure whether it could be repeated. And what was found was that in target blood pressure, so this was controlled, so no higher than 150 over 100, but not so low, so in a reasonable range without fetal compromise at 6 hours. And this was achieved in the majority of the women, whether it was nifedipine, labetalol, or even the oldie but goodie methyl-dopa, so the 1 gram, although this was 76.4%, was slightly lower than nifedipine. And if you looked at whether this in-target blood pressure without problems for the baby could be achieved without additional medication, of course, methyl-dopa was lower, but still 63%. This is the wrinkle in this, that nifedipine was associated with an increase in neonatal care unit admissions, 18% versus 10% in the other 2 groups, and this was significantly more. And these NICU admissions seem to be attributed to admissions for low birth weight or very low birth weight, so 12% in the nifedipine, and then a similar percentage in the methyl-dopa. But to sum up, success was achieved in the vast majority, like at least 75% in each of these 3 groups. And again, I think this is great news for treatment of severe hypertension, because it means that we have choice. The success with a single drug is driven by the 1 gram of methyl-dopa. Because if you'll recall, it was 83 and 77% if you just used oral nifedipine or oral labetalol. So continue to treat non-severe hypertension in pregnancy and postpartum, because prevention is best is the 3rd part of this. Now I want to just finish with discussion of timing of birth. We have some really great information now about how to time birth in women with preeclampsia. It started with the Dutch leading us in the HIPPOTAT trial in 2009 at term for women with gestational hypertension or preeclampsia. They followed up with HIPPOTAT 2 in 2015, which looked at women who were at the late preterm gestational age, 34 to 36 weeks. This trial was replicated, the Phoenix trial, in 2019, and then this information was put together in 2019. And I wanted to just sort of summarize this information in a grid. The expectant care, so I'll just explain the gestational age groups here. This is viability until 33 plus weeks, so the very preterm crowd. Then we have late preterm from 34 and 0 to 36 and 6. And then we have term 37 and 0 or beyond. And here we have, for the rows, we have the hypertensive disorder type. And we have chronic hypertension, gestational hypertension, or preeclampsia. And for chronic hypertension or gestational hypertension, expectant care should be undertaken unless there's an indication for birth at anything before term. And expectant management for preeclampsia can be considered in the under 34-week group, but only in perinatal centers capable of caring for very preterm infants, of course. For the late preterm, we have information from the Phoenix trial and the HIPPOTAT 2 trial that suggests that women do better if they're delivered rather than having ongoing expectant care when they have preeclampsia in this gestational age range, 34 and 0 to 36 and 6. However, there does seem to be some increase in neonatal risk if you proceed with immediate birth. And in HIPPOTAT 2, that was associated, there were respiratory problems. In the UK, in the Phoenix trial, they didn't see an increase in those respiratory problems, but 60% of these babies received antenatal corticosteroids. And most places in the world don't give antenatal corticosteroids to accelerate fetal pulmonary maturity after 34 and 0. Now, I mentioned the individual patient data meta-analysis, and this is where this subgroup comes in. So between 36 and 0 and 36 and 6, there was maternal benefit, but no increase in neonatal morbidity. And so the question is, should we break down this late preterm group and actually advocate for timed birth, so in women with preeclampsia at 36 plus weeks? I think we'll probably need some more information to convince people of this, and we need more information from different settings where steroids are used and where steroids are not used. But I think that this is a very important subgroup to think about. At term, it becomes a little bit easier. Let me work from the bottom of the table up. So initiation of delivery is, of course, recommended for women who develop preeclampsia at term based on the HIPPOTAT trial. For women who present with gestational hypertension and they're already at term, getting on with it is also suggested to be of benefit in the HIPPOTAT trial. The one caution I would make here is that in HIPPOTAT, they used the traditional definition of preeclampsia. It was only hypertension and proteinuria. And therefore, in the gestational hypertension group, you had a lot of the women who we now label as preeclampsia, right? We've moved the women who don't have proteinuria but do have low platelets or fetal growth restriction, we've moved them into the preeclampsia category. And so whether women with the new definition of gestational hypertension will benefit, I think is a bit unclear. And certainly in the UK, the NICE guidelines still do not recommend application of immediate delivery for women with gestational hypertension at term. Now, what do you do with women, like women who are enrolled in the CHIPS trial, who have chronic or gestational hypertension, and they're coming up to term and everything's okay, they don't have an indication for birth yet? Should you get on with things and induce them at a certain gestational age, or should you carry on waiting? And observational data suggest that between 38 and 0 and 39 and 6 would be reasonable. But we don't know whether if you aim for the earlier part of this, you will increase neonatal morbidity and decrease maternal risk in stillbirth. And if you aim for the later part of this, whether you will increase stillbirth and progression to preeclampsia, but decrease neonatal morbidity. So we're doing the WILL trial to try to answer this question in the UK. So in summary, preeclampsia should be defined using the broad definition, and that has some implications for evidence in other areas as I've highlighted for timing of birth. That antihypertensive therapy should be used for non-severe hypertension to prevent severe hypertension and to treat severe hypertension when it occurs. And that severe hypertension as an outcome is very important, and it's independent of preeclampsia. So in women with preeclampsia, it really must be taken very seriously. The term severe preeclampsia should not be used as the disease is unpredictable and the term doesn't help us with timing of birth, and expected care should be considered for anyone with pregnancy hypertension at under 34 weeks and at term delivery indicated for preeclampsia. And I just want to thank you very much for your kind invitation and your attention today. And my email address is there at the bottom if you have any thoughts on the presentations, suggestions for improvements, ideas, comments, questions. Thank you.
Thank you very much, Professor McGee, for this very beautiful lecture. I know your experience, and because the facilities where you practice may be a little bit different from what we practice here, because the neonatal facilities and maybe the practice of our obstetricians, because some of them, they don't have the backup of internist or obstetric physician to support them. So most of the decisions taken by the obstetrician himself, rather than going back and discuss the issue with the physician. However, I think things improving in Jordan, and I think Dr. Maher knows that, and he has a lot of experience in medical disease and pregnancy. I have to ask you, Professor McGee, you mentioned that if there is a preeclampsia, the expectant management only if the blood pressure, is it limit up for the pressure, what you allow it to maintain the expectant management?
Yeah, so expectant management is predicated on the ability to keep the mother safe, of course, and and I'm advocating tight blood pressure control during that time. Women in the CHIPS trial stayed in their arm, and they benefited from that blood pressure control. So if you cannot adequately control a woman's blood pressure, then expectant management should be perceived as dangerous. And as you say, expectant management is time consuming. It's very difficult to do unless there's the appropriate team, and unless you have access to individuals who can take care of mothers or babies when things start to go in an untoward direction quickly.
Thank you. You mentioned that with severe hypertension, you need to reduce the blood pressure by a percentage of 10% per hour. But if a woman is coming with an emergency and the blood pressure is coming down, but slowly at less rate than 10% and not reaching the level which is 140 or 150, can we do cesarean section or emergencies if the blood pressure is higher than this?
So, yes, for the 140/90, and ill-advised for the 160/110. And so the reason why I bring up how the rate of fall that we aim for outside of pregnancy is just to to illustrate that in general, the aim is not to drop things quickly, because of course in the non-pregnancy group, we're very worried about the brain, and in pregnancy, of course, we're very worried about the brain and we're very worried about the placenta. You want to be getting it down under 160/110 reasonably quickly, and then carry on with antihypertensive therapy and see it going in the right direction. But as soon as it's no longer severe, and as long as your anesthetist, if you're intubating, is cautious about endotracheal intubation induced increases in blood pressure, then that's absolutely fine. It doesn't have to be under 140/90.
Okay, thank
Dr.
you.
Mazen, can I ask a question?
Yes,
please?
Maher, you can, please.
Okay, thank you. Thank you very much for the excellent presentation. You know that if we're discussing maternal mortality, you know the confidential inquiries in the UK, the deaths from hypertensive disorders gone down significantly.
Yeah.
I mean, in the last report, there are hardly few cases of maternal deaths related to hypertensive disorders or pregnancy in general. Now, in Jordan, we had our first 2 reports on maternal mortality. Unfortunately, we're still having ladies dying from hypertensive disorders and pre-eclampsia. The maternal mortality rate in Jordan is around 30 per 100,000. So we have to do a lot of work to improve those figures, hopefully over the next few years. So any advice on how to reduce the maternal mortality in those cases who are related to hypertensive disorders of pregnancy?
Yes, so I would now, I was the principal investigator of the CHIPS trial, so I declare my personal bias for antihypertensive therapy. But I think that antihypertensive therapy is underrated as a tool for us to use. So we've spent a lot of time and effort talking about magnesium sulfate for women with pre-eclampsia, and it's not that it's not important, but it is difficult to implement. We've spent a long time now, and we still have work to do. I would strongly advocate for the management of hypertension, and I really wanted to emphasize the Genuity oral antihypertensive trial because it again shows us options, and it shows us options for oral therapy, cheap stuff. And so I think that it's very important to treat blood pressure, 2, be conscious of maternal risk. So using the risk calculators, there's the Pre-Eclampsia Integrated Estimate of Risk score that NICE now advocates in the 2019 guidelines. It can be used at any gestational age, and it's the online calculator that uses oxygen saturation, which I would also advocate for maternal mortality because it picks up more than cardiorespiratory risk. But to actually formally look at the risk of your women, and that's where I would focus my energy. And I think implement, standing orders, so standardized ways of doing things.
Thank you.
Thank you very much.
Professor Laura, we have 2 questions from the attendees. The first question, what about ACEs as a drug of choice for to treat postpartum hypertension? And is it better than the CCI? My only impact of the CCI is the risk of postpartum hemorrhage. What do you think?
Sorry, I didn't catch the name of the drug. Sorry, which drug is that?
ACE inhibitors. ACE
inhibitors. Oh,
yeah.
So I think it's important to remember that ACE inhibitors then they do become part of our armamentarium, and I think captopril, because it can be titrated quite quickly, you can give a dose and then another dose in half an hour to get it. We should remember that we can use it. It's also very important to put patients back onto it when they were on it pre-pregnancy. However, it is more difficult to use than some of our other drugs. And I would I would also make the point that we're less familiar with using it in these patients. You know, and we need to watch their renal function if we put them on it as a standing drug. Now, the NICE 2019 guidelines do advocate the use of drugs like enalapril or quinapril after birth to try to decrease cardiac remodeling. But I think that remains to be proven by randomized controlled trial. And I think that the jury is still out. So my preference is still to control blood pressure first and foremost. We know that it's more important to control the numbers outside of pregnancy for cardiovascular health than it is to actually do it using one kind of drug or another.
Thank you. Last question for you, Professor McGee. What about the prophylaxis with aspirin in patients with risk factors? This is from Dr. Muhammad.
Yes, perfect. So aspirin was, you know, we loved it, we were disappointed in it, we were, you know, we ignored it, so Kypros Nicolaides has made aspirin, you know, fashionable again, and that's great. So he's shown us two really key things. The first is that the clinical risk factors that we use, like prior preeclampsia, chronic hypertension, etc., they aren't great at identifying the women who are likely to develop either preterm preeclampsia or term preeclampsia. Only the detection rate is, you know, it's around 40%. If we do the multivariable screening, if it's available to us, and certainly we can all ask a good history and measure blood pressure, we can pick up the vast majority of women who will develop preterm preeclampsia, but it's still rotten at term. It's still like 40% sensitivity. But we should definitely be screening for risk factors, ideally using a multivariable model and giving aspirin, but giving aspirin nevertheless. I don't think we should be giving universal aspirin for a number of reasons. It's a lot of women to give it to, and we do have, with large numbers, we do have some data from Scandinavia. Stephen Tong did a very, very nice analysis showing that there does seem to be some small increase in the risk of bleeding. It's tiny, and it definitely doesn't outweigh in any way, shape, or form reduction in preeclampsia in women at increased risk. But it's different if you go out and you give it to everybody. So I would continue to do risk-based aspirin. Yes, I would give aspirin to everyone. What dose would I give? If the woman's small, I think I would still give 81. If she's larger, 150. But we don't have a comparison of the two doses. And I would say don't forget about calcium. What's the average calcium intake in Jordan? In dietary intake?
Around 600 milligram, and we advise them to take 1,200.
Okay, that's great. So do you, because I think that's more than half of women could benefit from the preeclampsia reduction associated with calcium, which is about 50%.
Yeah, I know that. The Canadian study, I think that is it. Is it the Canadian study one?
No, sadly, no. but thank you for thinking generously. But I think, yeah, we don't want to forget about calcium. It has a much larger risk reduction than aspirin. So we need to be doing both.
Okay, Professor Laura McGee, thank you very much for this very nice lecture, and we thank you for participating with this webinar. I wish you and your family very nice weekend. Have a good dinner.
Thank you so much. Listen, have a fantastic webinar, and thank you again. It was an honor.
Thank you. We hope to see you in person next year when the end of the pandemic.
I haven't been to Jordan. I would love to.
Definitely, we would like to have you in the future.
Take care, everyone. Thank you.
Thank you. Bye bye.
Bye bye.
I think next speaker will be presented by my colleague, the president of the Jordanian Society of Obstetricians and Gynecologists, Dr. Mohammed Al-Madani, He's going to present the next speaker, Professor Dr. Abdullah Adra. Please, Dr. Muhammad.
Muhammad, you're muted. Muhammad, put the microphone on, Muhammad, please. Yes.
Thank
now.
you. I have the pleasure to present my friend and our friend, Dr. Abdullah Adra from Lebanon. He is professor at the American University of Beirut. He is known for all of us, and his topic is about evidence-based management of postpartum hemorrhage. Please, Dr. Abdullah.
Masal khair, and
Noor.
good evening to all. I would like to thank Dr. Mazen, Dr. Maher, and Dr. Muhammad for the invitation. سلامات لكل الزميلات والزملاء الأعزاء في الأردن الحبيب، وإن شاء الله على أمل اللقاء القريب بظروف أحسن وأيام أفضل.
إن شاء الله. شكرا.
When Dr. Mazen invited me to be part of this webinar and asked me to present on obstetric emergency, I said, let's do the evidence, the management of postpartum hemorrhage. I understand and I fully recognize that this is a classic topic, but as he mentioned in his introduction of the webinar, this is one of the probably the most important emergency that any obstetrician would face. And despite all what we know and all our knowledge and armamentarium and interventions that we have done to reduce, to prevent, and even to treat postpartum hemorrhage, it continues to be the nightmare of obstetricians. So I think it's really worth to talk about. So in industrialized countries, PPH usually ranks in the top 3 causes of maternal mortality, along with embolism and hypertension. But in the developing world, the WHO suggests that 25% of maternal deaths are due to postpartum hemorrhage. And you can see clearly here that postpartum hemorrhage accounts for 13% of maternal causes of mortality in developed countries. But in countries like African and some Asian countries, it's almost accounting for 1/3 to 40% of maternal death. Unfortunately, this incidence has increased over the years. It's almost considered today around 5% of deliveries. Atonic related to uterine atony, PPH, has also increased, and the recurrence of the condition is considered up to 15%. We instruct our junior faculty, our residents, our students, there are risk factors for the conditions, a risk factor for atony, like with the prolonged use of oxytocin, the multiple gestation, fibroid uterus, the risk for genital tract laceration with operative vaginal delivery, the risk for retained placental tissue with the epidemic of cesarean and the adherent placenta, the abnormality of coagulation that we're all familiar with, including risk factor like fetal death and placental abruption. But unfortunately, PPH is considered an equal opportunity occurrence. So 2/3, in fact, of women who experience PPH have no identifiable clinical risk factor. And that's why we should be ready for the condition whenever we deliver a patient. Recognizing the risk factor is important, trying to prevent the condition. This is what we have been doing for a long, long time. What's agreed on between FIGO and the International Certified Midwifery Statement showing the active management of the 3rd stage of labor, including the use of uterotonic agents, the early cord clamping, controlled contraction, uterine massage, and delivering the placenta manually if it doesn't separate by 20 to 60 minutes. This is what we practice, but not all the time this is preventable. And I think one of the reasons that postpartum hemorrhage continues to happen is because of a delay in diagnosis. And the delay in diagnosis has to do with the lack of consensus for postpartum hemorrhage definition, underestimation of the speed and the extent of the hemorrhage, lack of an easy-to-use action plans or protocols, and lack of adequate education and training. So we all know since we were medical students that this is a classic definition, more than 500 cc following a vaginal delivery, more than a liter following a cesarean. I think irrespective of the numbers, and we're not very good at numbers and estimating blood loss, any decrease in hematocrit level more than 10% of prenatal value, and any bleeding that results in sign of maternal hemodynamic instability should be considered a fitting the definition of primary postpartum hemorrhage. The other issue is that we usually underestimate the blood loss by 30 to 50%. And there is no doubt that teaching how to estimate blood loss improve accuracy. I always talk to our residents that whenever we're trying to finish the C-section and they are writing their operative note and mentioning the estimated blood loss was around 300, 500 cc. And I say, did you look at how many pads did we use and how much these pads were soaked and how much was there in the suction bottle, although there was, it may be mixed with amniotic fluid, to discover there were at least between the pads and what's in the bottle after you take the amniotic fluid and the sheets, that there are at least another 500 to 800 cc. So we're over 1,000. So estimating blood loss is really important. Although we're familiar with the 4 T's of postpartum hemorrhage when it comes to etiology, the atony that accounts for 70%, the trauma for the genital tract lacerations, retained tissue for retained placenta, and the blood not clotting for any coagulopathy, whether acquired or congenital, factor deficiency. I think the most important to also remember would be the really not the primary one, because this is something that's even more perplexing and more sometimes tricky to find out the reason why a woman that is 4 or 5 days or even a week after delivery comes in with this significant postpartum hemorrhage. And this could be due to subinvolution of the placental side, retained products of conception sometimes, especially following a vaginal birth, infection, or sometimes factor deficiency like von Willebrand disease, which actually may manifest later on after 2, sometimes 3 weeks, 4 weeks, when they go to their pre-pregnancy level. This is when they start having the bleeding again. When it comes to the medical management of PPH, of course, this includes the monitoring with the estimating, as we said, the blood loss and monitoring vital signs, and the resuscitation with the fluids and the blood products. And the most important is to remember that the first line are the uterotonic agents. We're all familiar with what we have in our armamentarium of medications. Oxytocin is our best friend. It's the same drug that we use to stimulate or induce labor. It's the same drug that will cause uterine contractility. Methergin or methylergonovin, 15-methylprostaglandin F2 alpha, and misoprostol, especially when some of these drugs may not be even available. But in most tertiary care centers and maternities, the first 3 drugs are usually available. We should be familiar with their side effects, their contraindication, and the frequency of administration. All our residents practice this in every drill that we have. We have 2 drills a year for the postpartum hemorrhage drill. They have to be familiar with the dosage, with the route of administration, with the frequency of administration, and with their adverse side effects. So again, how much can we add of oxytocin? How much can we give methylergonovin? And what's a single dose of, for example, FIGO has used the 4 tablets as a single dose of 800 microgram of misoprostol. This is fine. This is good. But how about when medical treatment fails, when the uterotonics are given and the patient continues to bleed and atony is not responding? And this is the thing here, that there is not a single trial that has identified or dealing with surgical techniques. What's the next step? Is it radiologic intervention? What are the hemostatic drugs for women with primary PPH that are unresponsive to uterotonics? Of course, we're all familiar that simply rubbing the fundus and emptying the bladder sometimes is enough to do the work, and there's a first-line management of PPH. But we're talking, again, in patients who have failed the medical treatment, who have failed the manual compression of the uterus, and this is where we use the different techniques related to tamponading, whether we use a large Foley catheter, whether we pack the uterine cavity with sterile gauzes, And the different techniques have been used. Some maternities have the balloons, the battery balloon. Others have another form of tamponading using even small Foley catheter or a large Foley catheter, actually a 60 milliliter pulse, and fill it with 60 milliliter saline. But actually, the intrauterine balloon is really the first line, if we can say it, surgical. Although this is not necessarily surgical, this could be used in both patients who have delivered normally, vaginally, I mean, or C-section. But it's the first line surgical in women who have where the uterotonics have been employed to arrest their bleeding and it fails. And in most cases, 4 to 6 hours of tamponade should be adequate to achieve the hemostasis. So this is the Bakri balloon. This is the Rush hydrostatic balloon catheter. These are different condoms, or even Bakri, or the Foleys, or the different Sanger-Steken Blakemore catheter. It's similar to what they use for gastric balloon or esophageal balloon. Now, I understand that there is a speaker that's following and going to talk about surgical management of PPH. What do we mean by surgical management? I'm not going to speak a lot about this, but basically, if there are retained product of conception, we need to do the curettage using a large spoon curette to really take this, especially if the placenta has been adherent or has been removed manually and is not complete when we check it before throwing it in the basket. Repair of laceration, stepwise arterial ligation, uterine and then tubo-ovarian and the hypogastric, the uterine compression suture, the pelvic embolization, and finally the hysterectomy. And it's not necessarily in this order, but I'm just covering this aspect, and I think the stepwise devascularization is something that we're all familiar with, and sometimes just ligating the uterine artery would be enough, and sometimes going even higher, ligating the ascending uterine artery and the anastomotic branch of the ovarian artery, what's known as the O'Leary stitch, would be sometimes enough to do this before going for the internal iliac and doing this. The compression suture, mostly the B-Lynch suture. This is what's something I had the privilege actually to meet Professor Lynch actually in Amman many years ago when you invited him for a seminar actually, or a workshop on postpartum hemorrhage, and he demonstrated how he used his B-Lynch sutures and how effective it is. And this has been definitely used in the literature to control postpartum hemorrhage. The overall failure rate, depending on where you read, can be up to 25%, leading to hysterectomy. And the risk factors for failure include patients who are elderly, multiparous, but the most important is the delay. So if you have a delay of 2 to 6 hours between delivery and uterine compression suture, probably this is where it's probably too late for you to put the stitch, and it will not be successful. So a stepwise approach that has been proposed by many people, and this is one study that looked at stepwise approach that include the Bakri balloon as a first choice, followed by the compression sutures in case of failure. We're talking about patients who have already, of course, received the uterotonic agents. So in patients who had the uterine atony, as we said, the uterotonic agents and the use of blood product, we continue to need the balloon tamponade, and then of course make sure that there is no once we end up going for a laparotomy, before putting the compression suture, we need to make sure that there is no, we do this arterial ligation of the different arteries, and then the compression suture. And then one quick test would be just to squeeze the uterus between your hands, and while the patient is in an autotomy position, and your assistant will look and see that the bleeding has slowed down. This means that probably your compression suture is going to work. And then embolization only if this woman is stable. And I will talk a little bit about this embolization issue because I have some concern about it. So specific second-line therapy for PPH include, again, uterine compression suture, 75% success rate, pelvic vessel ligation, the interventional radiology with embolization, and the recombinant factor 7A that I would like to talk about this a little bit in a few minutes. But again, when you look at the tamponade, the balloon tamponade, and the compression suture, they're comparable. And when you look at something like uterine hypogastric artery ligation, you see the the significant difference in the literature reporting on its efficacy that goes anywhere from 50 to 90%. I remember one of our teachers used to say this is like tossing a coin. So this hypogastric artery is not always the answer. And this is where you sometimes, after exhausting all your choices, you end up going for hysterectomy, but you don't want to be late for this decision, because a hysterectomy that is done late in a patient that has been now in DIC is going not probably to be not only useful or of value, but even would be dangerous, because the DIC is the culprit in this case. Some people have concern with this techniques, this embolization or uterine devascularization and compression sutures, and their effect on resuming menstruation or even pregnancies in those desiring it after having this procedure. And what's reassuring here in these studies, looking at reviewing the literature, that most patients who undergo these procedures end up having menstruation at 6 months, anywhere from 80 to 90%. And even pregnancies have been described in these patients undergoing compression suture and uterine devascularization, even embolization, in probably close to 75 to 85%. We have summarized the whole thing that I have talked about in a classic textbook on perinatal medicine. I had written this chapter many years ago. We have included many cases. It's a very good reference with all what I have mentioned earlier on the surgical management of postpartum hemorrhage. I have written this chapter with Professor Mahideen Saud and myself, and we have included all our cases from the American University at that time. Now, one thing that has been a source of controversy is the use of recombinant factor 7A in massive intractable postpartum hemorrhage. The rationale for the use of Novo-7, as you know, Novo-7 or factor 7 is mostly used for patients who have factor deficiency, like the hemophilia. But the rationale for using in postpartum hemorrhage is that the use of blood product associated with an increased risk of infection, and especially when you have massive transfusion complications such as multiple organ failure and ARDS. Emergency peripartum hysterectomy, even in a patient who is multiparous, and even if somebody who has 3 or 4 kids, is psychologically traumatic. Arterial embolization is not readily available in most developing countries, and try to find out when was the last time you did arterial embolization. Either the patient is not stable enough to have the procedure done, or the intervention radiologist is not available, or she cannot be transferred to the right place. So because of this, there were potentially promising case reports on the use of recombinant factor 7. And the largest experience comes from the Northern European Registry from Europe, that include 7 or 8 European countries listed here. And in this series that included 113 cases, there was improvement in 80% of the women with few adverse effects, and it failed on only 13% or 14% of the cases. And one single dose, that is 90 microgram per kilogram, was enough to achieve hemostasis, and in these patients, probably it was useful in even trying to save their uterus. The American Congress of OBGYN has listed this in their bulletin, technical bulletin, which was again reinstituted again in their follow-up or in the most updated version, that it can be used and it acts on the extrinsic clotting pathway. You can use it until you achieve hemostasis. And I think what we have been using is what's mentioned here about this as an alternative use for a uterus saving therapy, and not as a last resort therapy. Because again, if you follow specifically the algorithm of using these patients who had medical intervention, whether the uterotonic agents, the tamponades, they have already required maybe a blood products. In this specifically, we're talking about patients who may have received 4 units of RBC, 4 units of fresh frozen plasma. And in this case, with the sustained postpartum hemorrhage, and before proceeding with your hysterectomy, there has been this algorithm suggested by the New Zealand Task Force guideline for the use of recombinant factor 7, where you can use a 90 microgram per kilogram as a single bolus over 3-5 minutes. So while you're getting yourself prepared to have the hysterectomy done, and your anesthesiologist had administered the drug, you have the answer. So if you can consider a second dose. Also, most of the time you don't need it. If you think the bleeding has stopped, and you can stop here and reverse the decision for hysterectomy. And if the bleeding continues and persists after 2 doses of recombinant factor 7, this is where you may consider the hysterectomy. We have had this experience of over 8 or 6 years, actually, where we had in our maternity, where we do almost 150 to 180 deliveries per month. We had 15 cases of severe PPH over 6 years, where Noble 7 was used after the medical treatment and the use of blood product. The bleeding stopped in all cases except one, and then one hysterectomy was done, and the single dose was used in all cases. We never used more than 1 dose. This is for the sake of time, just showing you the characteristic of the first 7 cases, where you can see most of them have received the blood already, have received the uterine artery ligation, had suturing, had uterine packing, and eventually most of them have risk factors, although some of them were following vaginal birth without risk factors. But I think this is something to keep in mind. So again, the advantage of recombinant factor 7, I know it's expensive, but you know you have to have it part of your armamentarium. And sometimes you would not believe that patients, where you sometimes offer them the drug, and when it works, and it really saves the women from having many blood product transfusion and keeping her uterus, this would be something that they would appreciate. The disadvantage of the recombinant factor 7 is that it is less than 100% efficacy. There is nothing 100%, and it's not registered for PPH indication. So this is an off-label use. Although I can tell you that now there is something going on, and I think pretty soon we're going to have another indication for the use of recombinant factor 7, and PPH may be listed. The studies are ongoing, and the results are very encouraging. Another medication that has been used is tranexamic acid. You're all familiar with the women trial and the use of tranexamic acid for the treatment of postpartum hemorrhage. You know, tranexamic acid has been used in many surgeries, in trauma surgery, in liver surgery, and it has been shown that it inhibits fibrinolysis with no effect on clotting parameters. It has been used in trauma patients within 1 hour, and has been shown to reduce the risk of death by 1/3. And recently, in the last few years, with the women trial, a benefit was seen when it was given with 3 hours from birth, and that's why WHO today recommends the use of tranexamic acid in all cases of PPH, regardless of whether the bleeding is due to genital tract trauma or other causes. So any case of PPH, it's worth to consider the use of tranexamic acid. It should be administered at a fixed dose of 1 gram in 10 milliliters. So this is 2 ampoules. The ampoule is 500 milligrams. So we're talking about 2 ampoules that can be given over 10 minutes. With the second dose, that's another 1 gram IV if the bleeding continues after 30 minutes. And this has been shown to decrease the risk of bleeding and to decrease the risk of even hysterectomy in a non-significant decrease in the risk of maternal mortality, but worth to keep in mind and worth to have the blood, the Hexacel available, or the tranexamic acid. So as you can see, obstetrics, this is what's written in the first, the classic textbook of obstetrics, Williams Obstetrics, the first line on obstetric hemorrhage. This is the sentence: obstetrics is a bloody business, and we should avoid trouble. And avoiding trouble should be following anticipation, preparation, and management. And I think the first step out of the box that we should be always thinking about is identifying patients at risk. This is a way to categorize this patient. This is something that has been proposed by Professor Bahat Sibai many years ago in his textbook on obstetric emergency, where he classified the patient at risk for hemorrhage: antepartum code red, those who have accreta percreta, complete previa, abrupt plus dead fetus, or a pre-existing coagulopathy. Then you have code orange, multiple cesarean, or uterine overdistension, severe anemia, thrombocytopenia, or a pre-existing classical or vertical scar. These patients should not deliver in a small tertiaries, in a small center where products, blood products are not available, where you don't have the assistant, the facility of a surgeon to help you, the anesthesiologist, the vascular surgeon. Then you have the code yellow, where risk factor may include obesity, or the use of prophylactic anticoagulation. And the intrapartum risk factor include those who have fatty liver with HELLP syndrome, uterine rupture, code orange, twins in labor. So we can see this classification. The second thing that has been proposed, and I think this is something that every maternity should have, and this is when a specific protocol and guideline that has been trained by all staff, including nursing staff, including resident staff, including faculties, that what is first to be used, what's second to be used, and all of this is included in what's called a postpartum hemorrhage emergency trolley. Why should we have a trolley that's emergency for cardiac resuscitation, and every time any drug is being used, the next day the chief nurse has to come and replace whatever has been used and have the trolley ready all the time? The postpartum hemorrhage is a similar condition, an obstetric condition, emergency, where the trolley should include all the drugs that we can use, the crystalloid and the colloid solution, the uterine packing balloon. You cannot just run from one place to another to see if there is a packing balloon, or if you're going to use a Foley, or if the compression sutures available, which one to use, if there are gel foam or not. You know, all these drugs should be in a tray. The tray should be completely, every time it's being used, to be replaced, whatever is being used. And this is the only way to use it efficiently. So more recently, I think we have added to this trolley that we have a tranexamic acid, as I mentioned, with the Hexasil ampoule to be used intravenously based on the results from the women trial. And the third thing has to do with the patient safety checklist. So in a patient who has an estimated blood loss of more than 500 milliliter from vaginal delivery, of course, you're going to do the fundal massage, empty the bladder, classical. Use the oxytocin, the methyl ergonovin, evaluate for the retained product of conception, lacerations. But then if still now she continues to bleed and no response, and we have 1,000 liter, this is when you need to call for help. You need to have a second hand. You need to have a second obstetrician available. You need to get anesthesia involved. He should be on site with you in the delivery room or in the operating room. And this is where your blood bank should be now alerted to start preparing blood products for you. And you now consider yourself in a place where you're going to use maybe a massive transfusion protocol, where for each units of packed RBC, you're going to use 1 unit of fresh frozen plasma and 1 unit of platelets. So this ratio of 1 to 1 to 1, this is when you start using this. By the time the blood is now more than 1,500, and this is where now you're going to consider your second line therapies after your ureterotonics and your tamponade have not worked. This is where you go for your laparotomy, for your uterine artery ligation, the compression suture, or even the hysterectomy. And this is the last thing that I would mention as an algorithm for atonic PPH. This has been proposed by somebody that we all know, Sir Arul Kumaran, president of FIGO, president of RCOG, who has proposed, who is the chair of OBGYN in St. George Hospital in London, who has proposed this hemostasis algorithm, where you should assess the vital parameter and the loss, the rule of 30. You establish the etiology, the use of uterotonic, you massage the uterus, you start your oxytocin, prostaglandin use, whether intramuscular or intramyometrial. This is where how you compress the uterus. The rule of 30, anytime you have more than 30% blood loss, your pulse rate increased by 30, your respiratory rate by 30, your systolic blood pressure dropped by 30, your urinary output is below 30. All of this is a shock index, and this is the value of the golden hour. The golden hour is the time in which resuscitation must be begin to achieve the maximum survival with the arrest of bleeding. And Dr. Maher just mentioned the confidential inquiry into maternal death, the too late, too little thing. When it comes to postpartum hemorrhage, too late to administer the drugs, to initiate resuscitation, to give the blood product. The decision for surgery, there should be no procrastination. you should get your senior surgeon and anesthesiologist involved, anesthetist involved, and too little when you give not enough fluid or oxytocin or blood products or clotting factors. So fluid replacement and the use of fresh frozen plasma, these are guidelines from the anesthesia team in our department, how when to give the fibrinogen, the transfusion of platelet. They are readily involved in any case of postpartum hemorrhage, and you cannot do it on your own, because while you're trying or you're now in a laparotomy trying to do the uterine artery ligation or the hypogastric, you're not there to be able to manage the blood product components and the transfusion components and the fibrinogen. So this is why the team has to be coordinating this, and this has to be clearly studied by everybody, where hemostasis, we will continue with talking about the S with the stabilizing clotting, the bimanual compression, the 4 T's as we talked about to apply the compression suture, the systemic pelvic devascularization, and the interventional radiologies if there is a place for it, if the patient is stable enough and you have the facility and you have the expertise to do it before proceeding to your last step, which is a subtotal or a supracervical or a total abdominal hysterectomy, depending on the cause of the bleeding. So if this is something related to atony, most of the supracervical would be enough, while if it's related to an adherent placenta from a previous, probably you need to go for abdominal hysterectomy. So in order not to live in the shadow, we're all familiar with the story of Taj Mahal and how how this person Shah Jahan has lost his wife while giving birth to her 14th child from postpartum hemorrhage. I think all of us have to remember we need to be familiar with the causes. We have to continue our education and training of our junior colleagues, continue to do the drills, agree on a protocols for every maternity unit, have the emergency trolley for postpartum hemorrhage available, and have a patient safety checklist that we use to rigorously follow to be able to save these patients from unnecessary intervention, but at the same time, no delay in the management, and no delay in the diagnosis, and no delay in the intervention. I would like to thank you very much. I kept the time of 30 minutes, and I the rest of the presentation a wonderful time, and thank you one more time for the invitation.
Thank you.
Thank you, Dr. Abdullah, for your nice presentation. And I have some questions here from the panel. Carnaxamic acid is not available in Jordan. No, it is available. You find it, and it is very cheap. Dr. Aram Salhi, what is the time between given factor 7 and the decision of hysterectomy?
As I mentioned, Dr. Muhammad, and that factor 7, recombinant factor 7 acts really quickly. So once you give the right dosage, which is estimated to be 90 microgram per kilogram, so in an average of 70 kilo women, this is going to come to probably close to 5 ampoules. By the time the anesthesiologist has given this, within probably 10 to 15 minutes, you should start seeing improvement in the bleeding pattern, and the hemostasis is now better. And if you think this was not enough, you may administer a second dose, but maximum by 15-20 minutes, you should proceed with the hysterectomy if the bleeding persists. So it works quickly, and this is the advantage of the medication.
Okay. Another question. Do you recommend delayed cord clamping as a preventive measure of postpartum hemorrhage?
Well, I'm not sure how much this is going to help, although this is mentioned part of the joint statement by FIGO and midwifery, the International Midwifery Association. But I think most of us, when we are practicing delayed cord clamping, is mostly for the benefit of the child, and not really to prevent postpartum hemorrhage. I think the active management of labor should include the use of uterotonic and controlled cord traction and delivery of the placenta by manual massage. And if it doesn't come out within 20 to 60 minutes, Maximum, you should do manual removal of placenta.
From Lava Mohammed asked, what about the benefit of internal iliac ligation?
As I mentioned, most of the time, internal iliac is done after the gynecologist or the obstetrician has already exhausted the medical treatment, the tamponade, and probably the stepwise devascularization that he knows how to do. So uterine artery ligation or the O'Leary stitches and these kind of sutures. I think by the time most of the internal iliac are done, what we're seeing is not necessarily the effect of the internal iliac ligation itself. It's the effect of what we have done before. So it's a cumulative effect of the tamponading and the devascularization. So, but when you look at the literature, it varies a lot, the efficacy of internal iliac. It goes anywhere from 50 to 90%. And let's agree that if we want to do this, it is only for those cases who have uterine atony that's not responsive. If you have a placenta previa percreta, accreta, if you have a lacerations, internal iliac ligation is not going to work. So I don't think this should be the answer. But again, there is so much variation in the literature. 50 to 90% efficacy.
Okay, Dr.
Okay, Maher Muhammad, may I ask a question, Dr. Abdullah? Thank you, Dr. Abdullah, for your very comprehensive and nice lecture. I know that working in a busy units, the problem is not in busy units where there are facilities and every equipment is ready to undertake care of emergency situation. The problem here in Jordan, I think Maher knows from our reviews to the maternal mortality, that most of mortalities and morbidities occur in hospitals where if delivery occur in facilities which is lacking expertise and equipments. That's why I think should be part of our recommendations in Jordan and in most of the countries in the region, that women should be delivered in hospitals where there is facility to take care of emergency, because we don't know when emergency may arise. Any woman may be straightforward coming to labor and all of a sudden she will get severe atonic postpartum hemorrhage or even trauma. And I think it's important that everyone should be prepared for emergency. The other thing, I agree with what you said, that it is a multidisciplinary problem. I don't think one single hand or a gynecologist obstetrician alone can manage a severe postpartum hemorrhage where there is shocked patient, a massive hemorrhage, facilities cannot be controlled. I think where I agree with you that a hematologist, where a facilities for the lab to give you immediate result, because we know that blood loss may be very fast and rapid and DIC may occur so rapidly. The other thing, you may need hematologist, you need internist, you need a properly trained anesthetist and intensive care unit. And last thing, I think it is our responsibility as teacher and responsibles of busy units is putting early warning signs for women who may develop emergency, because there is a lot of guidelines written on this early warning signs. I think hospitals should have this, and it should, every person in charge of unit should train and discuss these issues with his staff, nursing staff. So early warning system and drilling the staff how to deal with emergency. And the last thing I would like to say, that there should be debriefing of the emergency and actual events, because we need to identify the strength and appropriateness of our practice so we can improve our practice in the future. So these are my comments, and it is
fully agree, Dr. Mazen, and some of the things that you've mentioned, I have alerted to that. Although it can happen with any woman, but there are women who have risk factors, who are categorized as high risk for anti or intrapartum hemorrhage, and these patients should not be delivered in any facility, obstetric facility. The important.
Yes. Sorry, Brahim, where are you?
Questions you have? What's the
دكتور في عنده مشكلة في النت.
Okay.
Dr. Muhammad, can I just add something, please? Dr. Abdullah, can you hear me? I think maybe Dr. Abdullah is having a problem with his net.
No, I can hear you.
Yeah, okay.
Excellent, excellent. Oh, thank you for the excellent talk. The problem with bleeding is it's number one cause of maternal death in Jordan and most likely in the Arab world as well. So that's why it's a very important subject. And I think the problem is that our juniors or even the specialists are not taking the decision on the right time. And that's why we're delaying the decision and then we're stuck with the maternal deaths. Because if you call the best surgeons, the best consultants late, then you are in trouble. They cannot do much, unfortunately. And that's what we're noticing. And following what Dr. Mazen was saying, that most of these maternal deaths, they start in the peripheral hospitals and then they're transferred to the tertiary hospitals when, unfortunately, sometimes it's too late to save the woman. So that's very important. And I think all maternity units should have their own guidelines, their own protocols that they should follow. And we believe this is a very important subject, and that's why our webinar in 2 weeks' time is to discuss maternal mortality in the Arab region. We're going to have speakers from Tunisia, Lebanon, Egypt, and Jordan. And I think I'm hoping that all the participants today will attend this webinar so that they will know what are the causes of maternal death in their countries and what are the experts are going to do to reduce the maternal mortality in the region. Thank you.
Dr. Muhammad, if you would allow me to answer quickly 2 of the questions about the use of recombinant factor 7. Recombinant factor 7 is not something to be used as a first line. This is a last resort. So you have already used your drugs, you used your Bakri balloon or tamponade, and even you are almost there to do your hysterectomy. And this is where you can try it. So no, it is not a first line. And second, if you want to do internal artery ligation, yes, it has to be done on both sides and not on one side. And the last
Question,
thing is you use the uterotonic drugs, you use the balloon, the patient continues to bleed, and you're suspecting there may be a vascular reason for the bleed or the atony that's not responsive to the classic treatment. And after making sure that there is no retained product of conception, this is where you should proceed with your laparotomy. So this is the exact timing of the transfer from a vaginal delivery to a laparotomy to look for a possibility of compression suture or stepwise devascularization or even hysterectomy.
Okay, thank you, Dr. Abdullah.
Thank you so much. Thank you for
Thank you, Dr. Abdullah.
Thank you.
Shukran. Thank you.
Shukran, Dr. Abdullah. Thank you very much for your...
I let my colleague, Dr. Maher Maatla, to present the third speaker. Please, Maher.
I think Dr. Mazen can do that. He's got...
Okay, Dr. Mazen.
Dr. Mazen.
Okay, doesn't matter, Maher. You and I the same. Okay, thank you, Muhammad. Thank you, Dr. Maher. Our next speaker, Professor, I hope he will become professor soon, Muayyad Al-Azzam. Muayyad Al-Azzam, he is the consultant in Oxford University Hospital, John Radcliffe Hospital in United Kingdom. Muayyad Al-Azzam is an active member of our team. He participated in a lot of our activities, and he is a consultant gynecological oncology surgeon. Muayyad Al-Azzam is a dual certified obstetrician and gynecologist, subspecialist in gynecology oncology. He has MRCOG and he obtained the CCT accreditation. Muayyad is experienced unilateral surgeon for advanced and recurrent ovarian cancer and has special interest in microsurgery and fertility preserving surgical techniques. Muayyad served in the British Society of Gynecology Endoscopy and the British and Irish Association of Robotic Surgeons. Muayyad is a founding member of Oxford Placenta Accreta Group. He has extensive research and surgical experience in the management of trophoblastic disease. Muayyad Al-Azzam, I I welcome you here. I forgot to mention that Moed Lazam originally from Jordan, and he qualified from the Jordan University of Science and Technology in Irbid, and he moved to Ireland, and now he is in Oxford. Moed is going to talk about surgical management of abnormally invasive placenta. Please, Moed.
Thank you, Dr. Mazen. Thank you, everyone, for the kind invitation. It is always a pleasure to talk to colleagues and friends from Jordan. I think I'm going to answer one of the first questions. What do gynecologists we're doing here in obstetric session? It is coming from my interest in the management of abnormally invasive placenta. I've done some work in Sheffield during my fellowship training in trophoblastic tumors, and I see a lot of similarities between abnormally invasive placenta surgery and the trophoblastic tumor surgery. And hence, when I moved to Oxford, we set up the service to some form of advanced service for surgical management. I just want to follow on what Dr. Abdullah or Prof. Abdullah had mentioned. Obstetrics is a bloody business, and placenta, abnormally invasive placenta, is a real bloody business. And what we have been trying over the last few years is to change that bloody business, terrifying business, to a step-wise and fashion procedure where we can work out and predict the patients who are potentially going to end by major surgery and try to avoid all the potential emergencies and the maternity death. And I'm primarily going to discuss our technique, which we published in the American Journal of Obstetrics and Gynecology earlier this year, which we called it the SAC technique. So moving on, I have a couple of disclosures. As Dr. Mazen has mentioned, I'm a founding member of the Oxford Placenta Accreta group, and I'm also, you can see always the logo for an educational platform, which we call it Gyne Fellow, that I have founded or co-founded over the last couple of years, where most of the educational material that I develop with my colleagues is published there. So going forward, what we are going to cover today, I'll explain where the name of this surgical technique for the management is coming from. I will focus mainly on the surgical steps for the management of abnormally invasive placenta, share with you some of the videos and the pictures that we collected over the years, and hopefully we will have a time to discuss some of your questions and queries. It's actually the SAC coming from the initials of the three main players who developed the technique, and that's myself, my colleague, Mr. Sulaimani, and Dr. Collins. Both Human and myself are on the surgical side, and Sally is on the fetal medicine side of things. And between the three of us, with meticulous work and feedback and reflection, we developed this technique. It's basically, if I might say it, we it benefited from our expertise in gynecology surgery, and we brought it to the world of obstetrics. To move a situation where there might be a lot of emergency and change it from a reactive solution to a preemptive situation where we can anticipate the problems and deal with them even before happening. We meticulously review all these patients. We identify the majority of the patients through the antenatal, during their antenatal time, and that is mostly by our feto-maternal medicine colleagues with their ultrasound scan skills. Once the patients are identified, whether they are coming from our unit or from the surrounding unit, because we currently provide regional service, we get alerted about the patients as soon as possible. Once the time for delivery is planned, we tend to meet and discuss the particular patient the week before the surgery, and we do proper and a true multidisciplinary approach for planning the surgical treatment and the delivery for that particular lady. Fetal medicine representative, surgeon, either myself or my colleague, we know who's the anesthetist who's going to be on the day. We also have a representative from the midwifery team, the neonatologist, and so forth, everybody who is involved in the delivery of this patient. We review the scans, we review the medical condition of the lady, and all the demographic in terms of body weight and so forth. And by the end of it, we know what to anticipate pretty much from the surgery, and we put our, what we call it, the surgical plan. We decide, are we going transverse, midline incision, what we are going to do, and think about blood transfusion. And even if sometimes, if it is a quite severe condition, whether we want to have a standby vascular surgeon or not, because most of the cases that I get involved are the more advanced stage 3 type of cases. Then on the day of the surgery, then we produce the document which you are seeing on the screen. And this document, we go through it again as a tick box around 8:15 if on the day of the surgery. In our team huddle, WHO team huddle, we do our checklist and we ensure that everything is done. We assign another senior obstetrician at the time of the surgery to be the helicopter, and who will override his decision in terms of the dynamics of the theater, will override any other decision, and that is to ensure safety. Going to the surgical steps, we pay a lot of attention to how we are going to position our patients for the C-section and most likely hysterectomy or focal resection of the lower uterine segment. Our considerations are pretty much like what you all know, avoiding the aortocaval compression. We want to have adequate vaginal access in order to perform the hysterectomy. Have said that because we modified part of what we called the Hudson technique. We brought it into the gynecological surgery in one stage, which is the reverse hysterectomy technique. We think about the potential complications that might rise from long surgery, like deep venous thrombosis, nerve injury, pressure ulcers, and other potential complications like the Willich syndrome during this type of surgery. So what we do, put the patient on left lateral position. We do the modified Lloyd-Davis. We use gel mattress, but we don't use any sheets under it. And these are for two reasons. The first reason is we don't anything under the patient to soak the blood, because that will blind us to the vaginal bleeding in case there is any vaginal bleeding, which we cannot see it through the abdomen. And the other thing is with the sheets sometimes and long surgery, you might have ended by pressure sores and ulcers. We use clear drapes, so we see what is happening. We don't cover the lower part of the patient in a non-see-through. All of them are see-through, so that even if for whatever possibility of any bleeding, we get to see that during the surgery. We start with the incision. Our default incision, as you can see on the screen, is transverse incision, and we kind of modified, and here where the gynecology expertise coming in, we modified the malar incision to suit the abnormally invasive placenta surgery. So we do wide transverse incision, about 25 to 30 centimeter, from the anterior superior iliac spine to the anterior superior iliac spine. We meticulously dissect the muscle and the outer layer of the rectus sheath of the muscle, and then the inner layer of the rectus sheath from the arcuate ligament up to the umbilicus, or at times even above the umbilicus, in a midline fashion, to allow us to have access to the fundus and to be able to exteriorize the uterus. We do not do muscle cutting like other techniques, and also we do not interfere with the inferior epigastric vascularization. Sometimes, and in our pre-surgical planning, we think that sometimes the placenta accreta or the neovascularity extend to the lateral pelvic side walls, and we anticipate significantly worse hemorrhage, and these are the situations when we default to midline incision for easiness of access, because at this point of time we want to think and be able to access to the lower part of the aorta for aortic clamping in case of any emergency. The majority of our procedures, as I said, we perform them in a transverse incision. When we are inside the abdomen, and we do perform our initial survey, which combines of two steps here. The first step is looking at the lower uterine segment and the vascularity. Do we have a neovascularity? Do we have the bulge, or is there any invasion? And if there is an invasion, is the bladder involved, or is it going to the lateral pelvic side wall? That is a quick inspection and give us an idea while we are preparing for the delivery what we are going to do again. We use intra-operative ultrasound scanning to identify where is the placenta, because we plan our incision based on the placental location, and we try to minimize the blood loss as much as we can during this phase of the surgical procedure. Once the placenta is identified, we quickly tattoo the margins with monopolar diathermy, and then prepare for the fundal or the classical cesarean section incision. The video that is playing is a little bit old now, because with our fundal incisions, we tend to exteriorize the uterus, and we used to use the knife before. We moved away from this because we found that there is about 500 to 600 mils of blood loss straight away, even from the beginning, if we use the knife technique. So we benefited from the experience of our colleagues in the United States by using the staplers. So we now use the linear stapler, as you can see in the pictures on the left side, to make the fundal incisions. We just create the window, identify where the sac, and then between the sac and the fundus, and then do the stapler front and back. And this pretty much results in a bloodless cesarean section incision. So we don't have this problem of bleeding anymore. Before I forget also, I failed to mention that during our preoperative surgery, we do always, in these cases, do a cell saver. So all the blood that is lost, we pretty much retransfuse it back again to the patient. So that's quite important point as well. Once the placenta, the baby is delivered and the cord is clamped, we don't give syntocinon at all, because that results in partial separation of the placenta, the abnormally invasive placenta. We look at the uterus, and one of the early signs is the snowman, where the uterus will contract while the part that holding the placenta stays as it is, as you can see in the image. When we notice that, we perform for confirmation what we call the dimple sign, which is gentle traction on the spinal cord and watching the uterine wall. If the uterine wall goes inside while the dimple is performed, we know that this placenta is not going to separate. At this point of time, we have another discussion regarding what to do, and the majority of the times, depending on the severity, but the majority of the times, this would probably be a hysterectomy. If we decide to go ahead with the hysterectomy, then we start our preparations. We use two types of retractors, with or without. One, if we have a fairly extensive and advanced disease, or if we have a large BMI patient, then we tend to use the self-retainer bookwater retractor. If we don't anticipate upper abdominal disease or need for the aorta, or we don't need the midline incision, then we tend to use the Alexis retractor. I tend to use personally, in the majority of the cases, the Alexis retractor and another self-retainer retractor like Gallagher, where with the abdominal packing and keep the bowel away from the surgical field, and this seems to be working very well. Following that, we start always our surgeries going through the retroperitoneal access. I have to admit, as a gynecologist, I feel very nervous doing any surgery without knowing where I stand. This surgery is fairly bloody if there is any problem, and therefore we believe in the concept of you surround the enemy. The enemy here is the bleeding, and therefore at the time of the surgery, we prepare the field or the scene for the surgery from the get-go by identifying where are the important structures, what not to injure, and what to control at the time of the surgery. So we do an incision in the round ligament. We extend the incision laterally to the with the peritoneum up to the from the right the paracolic or the left to the paracolic gutters, pretty much on the just above the psoas muscle, and this is a very, very safe plane. You don't have any vessels as long as you are in the peritoneum and slightly mid to lateral from the psoas muscle. You are not going to cause any problems there. And then with one hand pressing or holding the peritoneum, the medial part of the peritoneum, we start to find where the landmarks. Here is the psoas muscle. If you can see my monitor, when I'm pointing, this is the external iliac artery. This patient has a little bit of neovascularization to the left pelvic side wall or to the pelvic side wall, and then slowly we find where is the ureter here, just crossing the iliac bifurcation. I tend always to start my surgery by tunneling the ureter a little bit to start and find out where is the ureter, and we sling the ureter. So this is pretty much the one of the first steps we do. Once the ureter is tunneled or slung, I just carry on tunneling the ureter all the way through in preparation of the hysterectomy. And this is pretty much what we tend to do with our radical hysterectomy. So this is not too unsimilar to what we do. I appreciate a lot of my colleagues might say, well, we are not familiar with this. To be honest, this is not a too difficult step, and probably you will need some mentoring or supervision or help by a more experienced colleague, whether it's a gynecologist or a general surgeon or a vascular surgeon in your first few cases. But once you master this technique, then you identifying where is the ureter, and then also where is the internal iliac artery or the big blood vessels, then you are ready to perform this complex surgery with a high level of confidence. So once that is done, we just carry on tunneling the ureter, and as you can see, the ureter is to be tunneled medially rather than laterally, so that we avoid any vascular damage to the ureteric blood supply. So having done that, we move in our procedures to the blood vessels, and here we don't tie them, but again, the same principle applies. We like to surround the enemy. So we prepare our scene. And then what I tend to do always is identify the internal iliac artery. And here you see that is the bifurcation. That's the common iliac artery, external iliac, and this is the internal iliac artery. The most important part when you are doing this type of intervention is to avoid ligating the internal iliac artery in the first 2 centimeters, because this is where the posterior branch is coming from, and this is where most of the problems with the claudications and so forth happening. You want to do only the anterior division. And the anterior division is the easiest place, and where to control the uterine artery is to see the obliterated umbilical artery and just go a centimeter or so below that. That gives you enough control of bleeding when it happens. What I tend to do is to do, I put a loose tie around the internal iliac artery and I leave it there. If I have serious bleeding, which I cannot control by ligating the internal, uterine artery at origin or other measures, then I do not have to panic trying to get to the internal iliac artery. The ligation is ready, just tie it, and that most of the times resolves the problem. In more severe cases, and you will see the videos, and I'm sorry, I need to point out to our platform here with the Gyne Fellow, we tend sometimes to sling the common iliac artery so that we are ready even for a more serious bleeding. And here we just leave the sling as it is, because if needs to be, we use the vascular clamps to control the bleeding. We didn't have to use that in any of our operations so far over the last 3 years. Moving, having prepared the pelvic side walls, we move into the, what I tend to say it is the most interesting part of the surgery, which is the bladder. And the bladder dissection in placenta, abnormally invasive placenta or pericardia, is peculiar because once you reflect, most of these patients would have had the cesarean section before, as you already know, and once you reflect the peritoneum, bladder peritoneum, you see these wonderful and beautiful vessels that are coming in all directions. These vessels are quite dangerous. It's pretty much like going to a minefield. We pay a lot of attention not to injure them. What I tend to do initially, use the bipolar scissors to identify the plane and do the initial dissection. If I can find a plane between these vessels and the bladder or the uterine wall, I tend to use that first. My preferred instruments, I tend to avoid also ligation or putting sutures and ligation here. And while this is possible, talking to my colleagues from Egypt, Dr. Abdullah has his beautiful technique in Egypt. Being in where I am, I'm quite lucky. I have the I tend to use the ligature, and I tend to use here the short Maryland ligature, which both helps me to do the bladder dissection and as well as advanced bipolar device, control the bleeding without any need for any ligation or ligate clips or putting any suture. So that's the one of the most challenging steps I find it in doing this type of surgery, and that is dissecting the bladder pretty much without having to go inside. I tend to avoid and do my best not to get into the not to open the bladder. Personally, I didn't need to open the bladder in any of my cases, but we had electively opened the bladder in one patient where the placenta was totally through the posterior bladder wall. Having done all of the ureter identified bilaterally, vessels are controlled, bladder is dissected, the hysterectomy is pretty much, or the uterus is pretty much at our mercy now. So we tend to go from in a routine fashion, take the tubes out, leave the ovaries, and go along the pedicles straight away. Once we get to the colpotomy, which is the next challenging step, we put, because of the positioning of the patient that we used, we tend to put a swab on a stick soaked with iodine, and do ask one of our junior doctors or nurses or assistants who are helping at the time of the surgery to do what we call it, kind of antiversion, pushing that swab and antiversion, and then we identify do the anterior colpotomy, and from there we go back, take the uterine artery and take the cervix in a backward fashion. And that's what we call it, the reverse hysterectomy technique, and which is we tend to do it pretty much standard in all our ovarian cancer surgery. Having done the closure or the colpotomy and finished the hysterectomy, basically we move on now. Is pretty much I think the practice here depends on where you are and what you tend to do. Basically we like to close the vaginal vault with interrupted sutures, and here is a choice for the surgeon. Some people like the monocryls, others like the vicryl. Do we use drains all the time? If we are worried about any bleeding or any ooze at the end of the surgery, we leave a drain in. Otherwise, we don't do the drains in a routine fashion. And this is pretty much how we worked out to change a situation where it is frightening to a pretty much controlled situation. We had only one case where we needed to do blood transfusion in more than what we had or have on the cell saver. To date, we did not have any major complication, not a single ureteric injury. And for the cases also that we did internal iliac artery ligation, because we tend to go for the anterior division of the internal iliac artery, we did not have any long-term complications of our patients. Our outcomes over the last 3 years are fully presented in our paper, and we compared our results with the previous phase where this technique wasn't applied, and our morbidity has been significantly lower. I believe the most important message here is emphasizing what Dr. Mazen and Dr. Maher and Dr. Abdullah had already mentioned, and that is really these placenta accreta is a red flag. It should not be done in any hospital. It should be done in tertiary places or units where there is enough expertise. It's important to have the multidisciplinary approach, and by applying systematic work or systematic approach to the surgery of the placenta accreta, and knowing who's your anesthetist and knowing what you are going to do, you should be able to minimize the morbidity and the mortality of the patients, and not to leave it to the day to find out who's around and who's not around, because these are young women who should not die for any other reasons. And that is my presentation, and I do apologize again. We run our educational program on the Gynae Fellow, and tomorrow, for people who are interested in pelvic surgery and pelvic anatomy, Professor Muallim from the Charité in Germany is giving a lecture on that. So it's a free of charge, and everybody is welcome. And I finish my presentation here. So thank you very much, and I'm happy now to take any questions.
Thank you, Dr. Muayyad. Very nice presentation and very nice pictures from your patients.
Thank you.
I know not all gynecologists are familiar with exposing the retroperitoneal space and going to ureter. That's why I say exactly like what you said. It is a multidisciplinary team, and standard gynecological obstetrician cannot go, most of them cannot go for retroperitoneal space and mobilize the ureter and get access to the uterine vessels. So surgeon or urologist or gyne-oncologist are important assistants in this field. And you and SAC team, I think, have done a good job, because always when I see a placenta accreta spectrum, I always ask exactly what you said. I need, who is the anesthetist? He should be a senior person. And I advise my colleague urologist to be there, because I don't know to what extent maybe the bladder is involved. And this will be the question for you I want to ask. And how much blood do you prepare before you start your surgery? How many units of the blood? In my opinion or my practice, I at least prepare 8 units before. Although I never give 8 units, but I need to be relaxed during surgery, especially because in most of the private hospitals in Jordan, they don't have blood banks. So they get the blood from the central blood bank, which takes an hour or so to get in the emergency. So I prepare 8 units of blood and fresh pearls and plasma. What is your comment, Muayyad, on preparation of the blood, and what to do if you suspect placental invasion to the bladder, and do you rely on the mammogram or ultrasound, or just wait and see what you may face during the surgery?
So thank you. There are a number of questions here. How many blood, how many units we prepare? We have always 4 units ready.
Yeah, but you have blood bank in your hospital.
Yeah, we have 4 units actually ready in the fridge before we start. Yeah. So that's important for us, because again, you never know what's going to happen. And then we also have the cell saver. So we actually give the blood while we are operating. We recycle the blood. Any blood lost, it goes back to the patient. That is regarding the blood. The second part, I'll come to the bladder in a second. If a gynecologist or obstetrician doesn't know how to access the retroperitoneal, and I appreciate a lot of my colleagues, they don't know how to access the retroperitoneal, I think there are two options here. One of them is have a colleague, whether that is a general surgeon, because ultimately the management of the placenta accreta is for the obstetricians. The gyne-oncology will provide the expertise, but that does not mean this expertise is not transferable to the benign gynecology or an experienced obstetrician. It is a matter of getting used to the access and finding out. And because the pathology is, and this is a strong belief I have, the pathology is obstetrics, and having an obstetrician who does know where to go is quite important, because gynecology, again, we might be busy doing debulking surgery somewhere else. So if you can do it, fine. If you cannot do it, have a colleague. I like what happened with the endometriosis, with the advanced endometriosis. A lot of 5-10 years ago, everybody was doing stage 4 endometriosis. Now you have endometriosis specialists who are doing it, and they are very excellent benign gynecologists now who can access the retroperitoneal space. So it is a skill that can be taught, and I hope in the future there will be some form of advanced surgical specialist in obstetrics who will be able to manage the placenta previa and the placenta accreta, because they are on the rise, especially the abnormally invasive placenta. It is on the rise. With regard to the bladder dissection and how we look at it, we do trust our colleagues who perform the scan. We have Sally Collins, who is a fantastic clinician, and she does beautiful ultrasound scans. So we trust her findings, and I think fetal medicine and or obstetric medicine colleague whom you know and work with all the time is quite important, because you will end to know their expertise and their limitations, and you can work around it. The second part also, we do always our assessment. So we look at the vascularity, we look at the blue bulge, we look at the lateral pelvic side walls. Is the vascularity extending pelvic side walls or not? So we do a lot of preparation and evaluation at the time of the surgery. For the bladder, once you open the peritoneal fold, the picture starts to come quite clear. If there is a plane, and this is how I tend to do it, if there is a plane, and that's what we call it, the air bubble are forming up, opening up around between the uterus and the bladder, then there is always a chance, and then that plane can be explored. I always use the analogy, we can dance with these vessels because they are abnormal, so you need to go with this zigzag. Having an instrument that works well. These vessels are abnormal, so they are not they do not follow the normal pattern. They do not have the same structure like the normal vessels. So you need to have a device that is going to work. Having tried different things, I think advanced bipolar device is quite important. And by doing it, we avoid to open the bladder most of the times. Even if there is a bit of vascularity still left on the bladder wall, that's not important, because these vessels are abnormal. Once they are deprived from the blood flow, which is coming from the uterus, they will die with time. So I wouldn't be really too concerned. They are not part of the vascularity of the bladder wall. So in long term, there should not be an impact on the bladder wall. It's the deprivation of that. And I hope I answered your questions, Dr. Mazen.
Yes, thank you very much. I have a few questions from the attendees. From Dr. Mohammed Lava Mohammed, which scalpel do you use to incise the fundus of the uterus?
any scalpel that you have, really. We don't have any specific
Doesn't
scalpel.
matter.
It doesn't matter, really. That's not the more important with incising the fundus is knowing where to put the incision. Is don't put it in the placenta. So I think that's more important than the type of the scalpel. For the stapler, any stapler, whatever you have, 55, 85, whatever the unit have, and used by the your colorectal surgeons or general surgeons, if you have them, they work very well. The trick with the stapler is not to open the amniotic sac, because if you open the sac, then the fingers of the baby might come in, or you might cause an injury, cause more harm than benefit. So basically, open carefully. Don't destroy or rupture the sac. Put your hand between the uterus and the sac, and then this is the time when you can gently insert the stapler, and that's how we open it. We open it forward and backward, kind of to the posterior and to the anterior. We don't go lateral, because lateral might end by hitting branches of the uterine artery. So kind of these are the few tips there.
Thank you. I think one of the questions here is it possible to do phalansteal incision? But I think you answered this question. You need to do malar incision.
Malar, we do modified malar incision. The problem, and I think here is the concept. Abnormal invasive placenta surgery is a concept. What is the danger? The danger is bleeding. If there is a bleeding, what do you need? You need access to the blood vessels. So you need that access. Phalansteal incision gives you access to the lower uterine segment. It doesn't give you any access to the pelvic side wall.
Last question from our attendees, from Adib Hassan. Do you have experience with leaving the placenta to die with or without methotrexate?
We did, actually. We do. We have about 10 cases so far over the last 3 years by doing nothing. And funny enough, the indication for us not to interfere and do the surgery is when the placenta is extending to the pelvic vessels, because navigating the retroperitoneal space with abnormal vessels in the retroperitoneal space, unless there is a bleeding, we tend not to disrupt it and leave it there. We do not give methotrexate. The problem with these patients, they do, I'm sorry, myself, there is an echo. The problem with these patients, they do need intensive monitoring for for good 2 months at least. From the 10 patients that we left the placenta in, we had one patient who needed to go back to surgery, and this is the importance. If you are going to leave the placenta, A, the patient needs to be informed, B, she needs to have access to a named clinician who's going to be a point, or somebody that if the bleeding happens, she picks up the phone, she cannot go through a switchboard. And the 3, you need to have somebody who's going to come in and do the emergency hysterectomy. So from the 10 patients that we had, one patient only ended by having emergency hysterectomy, which I did about 3 months ago now. And she had hair bleeding 6 weeks post-surgery, and by the time she was about 15 minutes away from the hospital, by the time she got to theater, she already lost 2 units of blood. So, and we had to do a fairly quick hysterectomy for her, but it is feasible. You don't need to give methotrexate.
Thank you.
Can I just come in quickly?
Yes, I think.
Dr. Abdullah, تفضل. I'll follow you.
Just a quick comment. Dr. Muayyad, by the way, great presentation. I really enjoyed it.
Thank you.
I learned from it. But regarding this management, the expected management of placenta accreta, I really fully agree that there is no place for methotrexate here, actually. It may be dangerous. is totally different from methotrexate we give for active trophoblastic proliferation with an ectopic pregnancy.
Correct.
Where we have guidelines how much to give, when to repeat the SCG, how much to expect to fall. Here we're talking about a dying placenta. And if you look at the largest series of expected management coming from France, the only maternal death they had in the series is a toxicity from methotrexate. So I wouldn't really be very adamant about giving methotrexate. I don't think there are any guidelines to follow how much you give, when do you repeat the dose, how do you follow. And the second thing that I would like to mention is what you mentioned, is a patient is going with expectant care. She needs to understand there is a chance, 20%, that she may have a hysterectomy, an emergency hysterectomy for bleeding, at least in the coming 12 weeks after the initial surgery. And if her surgeon or her obstetrician is not available and is not willing to take this risk, and she is not willing to take the risk, I think this should not happen. These are patients that can come with heavy bleeding invariably on a holiday or in a weekend or whatever, and their obstetrician or their surgeon may not be available, and they think this is tricky to do. So I caution about this.
Sorry, I'll make a comment for Dr. Abdallah's comment. Totally agree. Full agreement. It's actually this lady who had the hysterectomy, the one that needed the emergency. I did it at around 12 night, and I had a full exentration the following day. So you just
I can understand.
So
20% chance of having an emergency hysterectomy, and it's not only for a few weeks. It can go up to 3 to 6 months sometimes to complete the resolve.
Correct. She had it 6 weeks. Okay. From our experience, the one was 6 weeks post cesarean section.
Maher, do you want to ask anything?
Yes, probably the last quick questions. I mean, do you get referrals, Dr. Moayed, from the peripheral hospitals? How many cases have you reported in your series? And do you do routinely MRIs or just a few cases where you do MRIs on those patients?
No, we don't. The MRI is, no, we don't do routine MRI scans. We do ultrasound scan, and if you have a good fetal medicine colleague who does ultrasound scan, pretty much you don't need MRI scans. But that's not the practice in all the units. You know, I know Sheffield, for example, they do MRI scans, and that's what they do. But for ultrasound scan is available, it is reliable, and it gives us enough information to make our clinical decision. So we don't feel that we need to do MRI scans. Do we receive patients from the units? Yes. What type of patients we receive and what type of patients we reported? We did not report the accreta in our publication or even the increta. It's all of them are per creta. So you're talking about stage 3 plus 3A, 3B, 3C. And these times we tend to do of these in a year, pretty much every other week, about 20, 30 cases a year coming from the different units. And these are the upper end of the spectrum of these surgeries, because the ones with no vascularity going to the bladder into the retroperitoneal space, where an experienced obstetrician can do the surgery without having to navigate retroperitoneal space or bladder placenta phase, then I don't need to be involved as a gynecologist because I am busy in the other, in my other job as it is. So that's what we do. To add to your comment, also, what is happening now in the UK, this service of abnormally invasive placenta service is actually going to be regional. So the NHS England are going for specialist centers, and it's going through the commissioning pathway now. And there are centers going to be, either your placenta accreta center or PAS center, and you could be local center for level 1, level 2, or you're a regional center. And there will be a named regional centers in the country to deal with the most complex cases, because there is a realization. The only cause of maternity, pretty much the cause of maternal death, remaining cause of maternal death in the UK is hemorrhage.
Hemorrhage.
So once that is done, and there are active steps to get that eradicated if possible. So you will see in the next 2 or 3 years. We are not far. Everything's been approved, so we are in the process of identifying these centers, and there will be some of the leading units in the UK. For example, that will be centers like George's in London, Oxford here, Sheffield, and some other places. But there will be that.
I think the important message as well for our colleagues in Jordan, Dr. Mazen, is that people should refer those cases to a tertiary center. And even in the tertiary center, people or teams like Dr. Abdullah was talking about, they should have the expertise to do these cases. So 20 to 30 cases per year is fair enough. So if your center is doing 20, 30, 40 cases a year, then refer them to the center. My worry is that in some hospitals, people, they don't have the experience to deal with these cases. And when they face these kind of surgeries, they are struggling and putting lives at risk. So maybe the message should be that tertiary centers and the team, not the individual, but the team of doctors who are looking after those cases should have the expertise. Maybe Dr. Abdullah, like we say, how many amnios do you do? How many CVSs? How many cord bloods you do? The RCOG guidelines. So we should follow the same with the Acretas.
Yeah, thank you. This is exactly, Maher, because it is not a routine service. It is not a primary center, and big centers should be where all these placenta accreta or placenta accreta spectrum referred, and because they have the experiences and they have the facilities and the blood facility. I think I remember Dr. Abdullah Adra from Lebanon last year or 18 months ago when you visited us in Jordan. You said in Lebanon you already started centralizing the care of the placenta accreta spectrum.
Sure. Yeah, it is the case. Absolutely.
Yeah. Okay. I think we should finish. Dr. Muayyad Al-Azam, thank you again for your excellent presentation, and we are looking for tomorrow's lecture in the Gynae Fellows. I leave the screen now for Dr. Muhammad Madani, the president of the society, to present our next speaker. Our next speaker, Dr. Muhammad, are you there?
Yeah.
Okay.
Our next speaker is Professor Muhammad Allam, Consultant Gynecology and Obstetrics, NHS, Lanarkshire, Scotland, and Honorary Senior Clinical Lecturer at the University of Glasgow. His topic is about surgical management of postpartum hemorrhage, clinical and training tips. Please, Dr. Mohammed, the floor is yours.
I would like to thank you very much, Dr. Mohammed. I would like to thank the organizing committee for inviting me to this nice meeting. So my talk today is about the surgical management of PPH, and also some tips and tricks to facilitate the procedures, and some tips also for training during this difficult situations. So in obstetrics, you experience huge highs, but also the worst lows. Things do not often go wrong, but when they do, it is awful. This is not my say. So we'll carry on. The final straw came during a hellish shift when I performed an emergency cesarean section on a woman with an undiagnosed low-lying placenta. The baby was stillborn and the mother lost 2 liters of blood. I was told to fear the worst. This are the says of this retired registrar. He is now a writer, Adam Kay, and he is writing nice medical books, and I advise you to read his books. This is going to hurt. So I think we have a responsibility to teach our trainees, and this is why in NHS Lanarkshire we created few methods for training trainees in an elective situation, these difficult procedures in difficult situations. So let's have a look. Intraoperative measure to reduce blood loss. I think my previous colleagues have been through all the options, but let's go through some of them. So we can do very simple measure, which is internal aortic compression if we have PTH during cesarean section. This is a fairly easy to do. The abdominal wall is lax, and this will give us a little bit of reduction of the pulse pressure. A common mistake to avoid is to compress the common iliacs, and this is by feeling the iliac vessels, and they need to be blocked. Both the pulsation need to disappear in both of them, and this way we know that we are compressing the aorta. So now, is there any evidence that prophylactic surgical measures like the bleeding suture and other measures are helpful in reducing the risk of death and after oxytocin and prostaglandin therapy fails? I think this has been presented before, and we know that the success rate is between 84 and 94%. However, again, I would like to stress that time is gold and we need to act quickly and swiftly. So, first method which is the first one of the surgical methods is the stepwise uterine devascularization, which this technique was created by Professor Sarah Abdurabbo from the hospital where I trained in Alexandria at Shadby Maternity University Hospital. This was published in the Green Journal in 1994, and this has been explained by my previous colleague, devascularization of the uterine pedicles and the ovarian pedicles here. Fairly successful and simple method for an average skills registrar to perform. So what about the internal iliac ligation? It was not an obstetric procedure before. It was an oncology procedure, as was explained by my colleague, Dr. Muayyad, and this reduced pulse pressure and is fairly successful as well. Okay, so this is some basic anatomy. This is the internal iliac artery going to feed the pelvis, and this is the external iliac artery. Now, the main task or the main trick here is, as Dr. Muayyad explained, is finding the ureter. So this is not a difficult task. However, I'm not preaching here for everybody to do that, but at least when somebody who does not have the skill is assisting during this operation, what we do is dividing the round ligament and open the peritoneum on the side wall, 10 centimeter kephalar. Then find the external iliac artery. Don't go for the ureter first. Find the external iliac artery and follow it to its bifurcation. And the first structure sitting on the artery is the ureter. So this is a cadaveric view of the aorta, common iliac, external iliac, and here is the main trunk of the external iliac. We can see it is short and quickly divides into posterior division and anterior division. Posterior division divides into three divisions here: iliolumbar, lateral sacral, and superior gluteal. And this is why it is important to go with the ligation a little bit low, 2 to 3 centimeters, as Dr. Muayyad say. And there is another reason why we should go a little bit low here, because as you can see here, there is the internal iliac vein, and this is the most important structure we would like also to avoid. We can see this is another cadaveric view, and you can see the more we go deeper, 2 to 3 centimeters along the anterior division, we can see that there is a window here between the vein and the artery. So if you put our instrument here, then we can hit the vein very easily, whereas here, this is only, this area is only covered by areolar tissue, as we'll see in the video very shortly, and then we can put our instrument in this area safely. This is the internal iliac vein here, and you can see 2 to 3 centimeters below the bifurcation. There'll be this safe window that we can do our maneuvers through. So here is again the right angle clamp is taking the ligation, and we don't cut the artery, of course, we are just ligating it. Now this is a small video from the YouTube.
Internal iliac artery ligation or PPH. Abdomen opened by funnel steel incision. This is the internal iliac artery, and separating the fibroareolar tissue on either side with fossets. This medial side, this is on the lateral aspect. So you must be very careful, especially when dissecting on the posterior aspect. Vein will be underneath.
We can see here he is actually scratching the artery. He's lifting the artery up. He's trying to be very, very close to the artery and not going below it.
Now thread with number 1 Y-grill. Now ligating the internal iliac artery with Y-grill. After that, I will check it with pulse oximeter. This is the ureter. One can appreciate the peristalsis. This is the psoas muscle with genitofemoral nerve. This is the external iliac vein. This is sacral promontory with median sacral vessels.
So this procedure is not without its complication. We can have up to 9% complication, like inadvertent ligation of external iliac vessels, external iliac artery, also spasm or thrombosis, buttocks necrosis if we ligate the posterior division. And there are quite a few major problems. The main one is this one, which is an example of necrosis of the buttocks, and this will need plastic surgery for reconstruction with a nice, fairly nice results at the end, but still it is a major surgery and major complication. This is why we have to be careful and don't consider it as an easy procedure. So we all know who is this, of course. This is Professor Christopher B. Lynch from Milton Keynes Hospital in the UK. I have the privilege of writing a paper with him and doing lots of courses with him as well in Alexandria University and Cairo. So his technique is the classical blinch and the transverse blinch. They are both saving lives, fertility, simple, quick, reproducible, and very cheap as well, with a very low failure rate. So this is really one of the important techniques that we need to learn for the average obstetrician and gynecologist and general obstetrician and gynecologist to be able to do. And they have almost similar success for atonic postpartum hemorrhage, like the internal iliac ligation, or even more. So the first procedure was done in 1989 with a massive PPH in a patient refusing hysterectomy. So the whole idea was to close all these terminal vessels coming from the uterine artery at the placental bed with the brace and belt suture. It is really a brace and belt suture. This is how it looks from anterior, and this is the shoulder of the uterus, the fundus here. The suture is coming above, and then at the end we are closing it like a belt from anterior and from posterior as well. So all the vessels going to the placental bed are compressed for a while. It's like imitating the bimanual compression. So this is a close view picture from anterior view above and below the cesarean section incision, and we will show also how to do it with a closed uterus. So this is from his website, and this is a live picture from a true operation, posterior view and anterior view again. So now the B-Lynch suture material that we use in Lanarkshire, and this is his suggestion also, is a blunt long needle, 70 millimeter on a 90 centimeter suture length, and we'll show you why it is very long at the moment, and it has a fairly short life. 60% of its strength will go after 7 days. So other compression sutures like the multiple square sutures and the Heyman technique, they are feasible as well and apparently effective according to the publications. However, the main difference is that they oppose the anterior and posterior wall and might create adhesions inside, and have been hematometria and pyometria reported from the multiple square sutures. So regarding the training for this emergency procedure, we published a paper in the BMJ from our Lanarkshire team using a wet ex vivo models, pork bladder and bovine uterus. So this is the pig's bladder here. You can see it simulates the uterus with its broad ligament and tubes here. So what we have done, and this is the bovine uterus. Here we can see the vessels going near the uterus here, big broad ligament, bladder, and the bovine uterus is didelphys uterus actually, as we will see. So this is a video of a training specimen for the B-Lynch suture with a cesarean section incision. So as we can see here, this is the cesarean section incision. We open the bladder. This is the bladder of a pig here. So the sutures are placed as indicated by Professor B-Lynch, 3 centimeters and 3 centimeter below and above. And then we go back at the uterosacral ligament insertion with the assistant helping, and then put the needle in the posterior wall and get it out anteriorly, and then again in the posterior wall at the same level of the uterus, just above the uterosacral ligament insertion, and again jump above the fundus of the uterus, and again 3 centimeter above and 3 centimeter below the cesarean section incision. Now, as you can see, this is a 90 centimeter thread of monocryle. So this will help the assistant to keep compression of the atonic uterus while the cesarean section is cesarean section incision is being closed. So you can keep the compression. Again, the compression is not by pulling, the compression is by the assistant, and then the extra lens is pulled by his other hand, and then we can close after closing the cesarean section incision, as closing the B-Lynch before closing the cesarean section incision, we can sometimes miss the angle, especially if there is an extension. So now, how can we do it with a closed uterus? And this is a very common question. So same uterus again. This is a pig's bladder. We do the pre-application test as indicated. Make sure that the compression bimanually will stop the vaginal bleeding. Check from down below, of course, after bladder dissection. This is the benefit of the big needle as well. It's 70 millimeter needle, 7 centimeters. So we go anteriorly and then above the fundus, and then again between the two ligaments, the two uterosacral ligaments from behind, there, and then again over the fundus, and then again at the same 3 above and 3 below, the virtual incision here. We have dissected already the bladder, and then we can have the same effect, and in this we can close the uterus. And this all, of course, will be done after making sure that there is no retained parts of the placenta and no clots inside the uterus. So what about the transverse B-Lynch now? So it is almost the same idea for the lower segment, that maybe after a placenta previa that is not stopping with normal measures. So again, we want to basically stop or strangulate this area here, which are the end branches of the uterine vessel. Okay, how are we going to do that? It's not as simple as the classical, because here we have on our way the broad ligament with its contents, vessels, and ureter as well. So we are aiming to compress this bit here, but if we go around the broad ligament, then in this case we are going to compress all this as well, which is obviously not needed. So what do? We use the transparency of the broad ligament, and we need to come very near to the uterine vessels here and spare all the ureters and the big vessels from outside, and also the ovarian and tubal vessels as well. How are we going to do that? We also, our team in Lanarkshire created a specimen, which is the bovine specimen here. I will run this video. This is for training as well, for trainees to be able to imagine and understand what's happening in non-emergency situation. We have run few courses in the west of Scotland with these specimens, and the feedback was fairly good. So now we are attacking the uterus from behind. All the B-Lynch, the transverse B-Lynch is attacking the uterus from behind. And then we went through the broad ligament, around the vessels from outside. This is a stay suture here to avoid slipping of the suture. Of course, the bladder is already dissected here for the cesarean section. Again, into the transparency of the broad ligament, we can see the vessels, we can see that we are very near to them, and then we can go now and attack the posterior wall, and again we will attack the posterior wall again. So all the attack with the needle are in the posterior wall. Now again, transparency of the broad ligament, and now we have finished our suture, and again this is 90 centimeter thread, and the assistant can compress the lower segment while the cesarean section is performed. We have just done actually one in Lanarkshire a few weeks ago, who had lost about 2 or 3 liters, and this was fairly successful, and patient preserved her uterus. So we have done a study with Alexandra University, Professor Ahmed Galal, and we presented these 10 cases in Rio, in the FIGO, 2018. We had a fairly good success, and it takes only 5 minutes to apply. Another study from Asyut in Egypt, which was also published in the Green Journal. They did 23 cases after the 10 that we have done in Shadby, and they had the same results in the same time as well. So it is reproducible. Okay, what about hysterectomy now? So what about hysterectomy now? So total hysterectomy after placenta previa for atonic PPH is indicated, especially if the cervix is bleeding. Subtotal hysterectomy can be done in unstable patient, and if the cervix is not bleeding and placenta is not accreta into it. So we have 10 to 20-fold increase in the peripartum hysterectomy, and the UK OS indicated a 0.6% maternal mortality from these procedures. So things to consider in the cesarean hysterectomy, that the anatomy is distorted, of course, because of the big uterus and edematous tissues. So the vascular pedicles are big and floppy. They can be twisted. So orientation of the pedicles are important. Double clamping or strong ligature like Impact or Atlas need to be used to avoid any post-operative bleeding. And we need to be careful with the ovarian ligament as well to avoid ending up in oophorectomy. So bladder also may be adherent, as was said before in this meeting by my previous colleagues. So we have to be careful with the dissection of the bladder. So also it might be difficult to identify the cervix if we want to do a total hysterectomy to open the vagina or receive the cervix from outside as well. So this can be a confusing point and may result in going back to theater. So friable tissues and easy bleeding of the planes and very vascular planes. And also we need to be careful if there are any tears as well. So our team in Lanarkshire, we created a technique that I'm going to tell you about before. We've spoken about the time, and Royal College mentioned that it is important to be swift and quick in making the decision to avoid severe complication and death. So what are the surgical concerns with the current technique of total caesarean hysterectomy and cervicectomy when patient returns back to theater after subtotal caesarean hysterectomy? What are the concerns here? So we have more surgical dissection into the depths of the pelvis because we need to dissect the bladder, the ureter, etc., etc. Disturbed anatomy, especially with previous surgery like uterovesical and Douglas pouch, can be completely obliterated by adhesions. Also need to dissect the ureter, pelvic side walls in a patient in critical situation. We might not have a gynecologist or somebody with the skills to dissect or open the pelvic side walls also. So possible unnecessary increased operating time in a patient in critical situation, increased risk of bleeding, infection, and complication as well. Also, in such young patient, scarring of the upper vaginal third can have long-term consequences. So, I'm a gynecologist, and in Lanarkshire, we do most of our surgery for hysterectomy in gynecology as laparoscopic hysterectomies. So we can see here the benefit of laparoscopic hysterectomy. This is a gynecology case. So the uterus is pushed up into the abdomen, away from the tiger land of the ureters and big vessels. Bladder here, as you can see, is only dissected 1 centimeter down. And the fornix here is very well identified by the uterine manipulator, which is lifting the uterus up and also identifying the fornices. So this is a gynecological case in an obstetric meeting, and you will know now why I did get this video here. So you can see here the fornix is open very high, length of the vagina is preserved, very little dissection of the bladder, no need at all to dissect the ureter or go anywhere near the pelvic side wall. So this, if it is an open procedure, is going to be a very, very nice simple hysterectomy, dissecting as a subtotal hysterectomy and achieving the goal of removing the cervix and a total hysterectomy as well. Okay, so what is lifting the uterus up do? Basically, this is a case of TLH as well, and you can see here the lateral pelvic side wall is open and paravesical space here. You can see the ureter down here, and you can see the coiled uterine vessel here. So now you can see when the ureter is pushed up, you can see the uterus is pushed up, the ureter stays back, and the coiled uterine vessel is straightened, and we are attacking the uterine vessel very, very high up, away from the ureter. So lifting the uterus up is very important to avoid the ureter and this tiger land of the pelvis. So in Lanarkshire, we use this technique that we presented also in the RCOG international meeting for cesarean hysterectomy atonic PPH and for removal of the cervix after return back to theater for after subtotal hysterectomy, subtotal cesarean hysterectomy for bleeding. This is the same idea exactly of the TLH, and is taken from TLH. As I mentioned, I'm not an obstetrician, I'm a gynecological surgeon. So let's have a look here. This is a bovine uterus. Now, this is the cervix here, and it is open with cesarean section. All what we do is to imitate the uterine manipulator. We put the finger or hand according to the space that we have. This is the bladder, just very, very small, maybe 1 or 2 centimeter dissection of the bladder. And we can see here, the finger is identifying very nicely the fornix, and the hand is lifting up the cervix or the uterus out with the pelvis totally, like exactly we have seen in the gynecological movie here, only this is an obstetric. So by lifting up, we also reduce the diameter of the vessels and reduce the bleeding. And now we have opened already the vagina. We just on the fornix here, putting our clamps or our ligature or any other instrument you would like to cut on, and then we just simply cut on the fornix here. The cervix is separated, the vagina maintains its length, the bladder is very, very small dissection here, very relative dissection here. We have not approached the pelvis at any time, and also the Douglas pouch, if it is obliterated by bowel or adhesions, we are not approaching it also because we are lifting up, and this is just at the level of the uterosacral insertion here. The cervix is nicely separated now, and now we can close the vagina. As you can see, it is in the air, in the abdominal cavity, away from all the tiger land of the pelvis. So this was presented in the RCOG International Conference in 2019 as well. And from our courses, the feedback from the trainees is really good. We also did a plastic specimen, just very, very simple, cheap, from a saline bag and its covering. We cut it as a cesarean section. The balloon is attached with a solid tape here, which is the bladder. This can be dissected by the trainee, and then they put their hand and open on the vaginal fornix. Only dissection needed is 1 to 2 centimeter max. So benefits of this, again, lifting the cervix and the uterus out of the pelvis. No need for deep dissection. Vaginal fornix is easily identified, much less dissection of the bladder, only 1 centimeter. No need to dissect the Douglas pouch as well. Much less blood loss, trauma, and much less time consumed in this critical situation, and also preservation of the vaginal glands. And this is the end of my presentation. I would like to thank my colleague who helped me to put these slides together, Dr. Evelyn Ferguson, Dr. Mohammed Hasseb, Dr. Mihai Gergi, and Professor Ahmed Fawzi Galal from Alexandria University. And this is Edinburgh Castle, if somebody wants to visit Scotland at any point. Thank you very much.
Okay, thank you,
Mohammed.
Dr.
تفضل ماهر محمد.
Thank you, Dr. Muhammad. If there is any question from the attendees.
There are no questions.
Okay.
Maher, do you want to ask anything?
Move to the last speaker.
Okay. Thank you, Dr. Muhammad. Dr. Maher.
Shall we?
Okay.
Okay, thank you.
Yeah.
I would like to introduce our last speaker, Professor Thomas, MD. She's Associate Director, Family Practice Residency Program from 1997 to 2018. She's an Obstetrics Clinical Assistant Professor, Department of Family Medicine, Loyola University Medical Center, Chicago, Illinois. She's a lecturer in the Department of Family Medicine at Finch University Health Science, the Chicago Medical School, She is a course director and advisory faculty for ALSO, which is Advanced Life Support in Obstetrics. We're delighted that you're with us today, and she's going to talk about a very important subject, maternal resuscitation and trauma in pregnancy. Professor Thomas, it's all yours. You're muted, Professor Thomas. You're muted. Yeah.
And can I share my screen?
Yes, please do. Yes, we can see the slides now.
Thank you. Yeah. Thank you, Dr. Mayer. That was very sweet of you. You've upgraded me to a professorial level. I was a clinical assistant professor there, but I will take it since I've already retired. Thank you very much. And it has been a pleasure to be part of this amazing, spectacular, scholarly group of speakers. So I'm really humbled to have been invited to be part of this. Dr. Meza and Dr. Madhani, thank you very much. And thank you to the Jordanian Society of Obstetrics and Gynecology too. I know it's going to be a little bit more easier on the mind and on the eyes, this topic of ours, but it is a very important topic, and it is a topic that requires a lot of teamwork and team effort and practicing of drills and identifying everybody involved in maternity care to participate and be on the same page. It is a concept where we are going to standardize the care, try to make everybody leaders, team leaders, rather than just team members. And we are also going to try and make sure that we use all our tools like the briefing, the huddle, the debriefing to make it a better scenario for the next emergency that we come across. So maternal resuscitation, and I'm part of the also advisory group, one of their advisors, and I'm your international representative from the also program. And I am using the contents of the chapter, which you will see in the also syllabus. I think this has been taken far and wide by me to the UAE, to India, to Australia, and it's all to the obstetricians, and they've all been amazingly grateful to having brought this course. You would be amazed to see how wonderful this course is and how well appreciated it is from a professor to the very least or junior most intern. So let's go and try to do some basics and get you all not too hypoglycemic. Okay. So where am I, Abhi? So we will talk a little bit about the aspects of maternal physiology that may affect maternal resuscitation and trauma during pregnancy. Describe the evaluation management of the major and minor trauma related to pregnancy, and also attempt the technique and timing for resuscitative hysterotomy, or otherwise called cesarean delivery too. Oh, it's not. Sorry, I should do it as a, okay. All right. So the introduction, what is it? What is the incidence of cardiac arrest in pregnancy? And why has it increased? We have seen it on the increase, mainly because of a couple of factors. We have found that older women who have medical complications are now getting pregnant and having babies. We also find that the assisted reproductive techniques have helped women who in the past have been asked to not get pregnant are now getting pregnant, and they have medical complications that may also make matters more complicated in management. And also there is an increasing rise of obesity. So we have noticed that about 50% of these maternal mortalities could be preventable, and hence all these various also courses that we are doing, because if you make everybody in maternity care being more aware of the situation and running drills and conducting scenarios where people of all spectrums come together to run a code team, we are able to improve the mortality much more. There is potential to improve this status. Also, the take-home message for today from me would be that when you are in the process of resuscitating a woman, the fetal outcome is directly related to the well-being of the mother. So you need to make sure that all your focus is on trying to bring about the well-being of the mother, and that will automatically make will improve the well-being of the fetus too. So what are the causes of cardiac arrest? We know of the non-obstetrical causes that can, which we all do when we think about ACLS and BLS, we think of all the non-obstetrical causes. But when you are dealing with a pregnant woman, you need to know some of the obstetrical causes too. And these are the big guns here are amniotic fluid embolism, eclampsia, HELP syndrome, magnesium toxicity, postpartum hemorrhage, pre-eclampsia, uterine atony, peripartum cardiomyopathy, and trauma. And some of these topics have been really gone in detail by our speakers, and makes you feel a little fearful, and you will attempt to try and identify how you can prevent getting into that sort of a situation. The non-obstetrical causes, you think of the anesthetic complications, the aortic dissection, bleeding, which can be non-uterine causes. You're thinking of cardiac disease, especially cardiomyopathy, cerebrovascular accidents, disseminated intravascular coagulation, sepsis, thromboembolism, and opioid overdose. So before we go into resuscitative measures, we need to know some of the physiological changes that take place in pregnancy, which can have an effect on resuscitation as such. So we know that pregnancy is a high flow, low resistance state, and it does not have any of the placenta. The uterine perfusion has no autoregulation, so it's directly dependent upon the maternal blood pressure. So if there's any drop in the maternal blood pressure, there is a drop in the uterine perfusion too. We also know that the plasma volume in pregnancy increases by about 40 to 50%. And this brings about physiological anemia in pregnancy, wherein you have a limited number of RBCs and you cause a decrease in the oxygen carrying capacity for that individual. Uterus also receives 30% of its cardiac output. So when there is a collapse, remember that the uterus might be the first organ to cause vasospasm and get this blood back into the systemic circulation. So you may not identify signs and symptoms of hypovolemia until there has been a decrease in blood or a loss of blood for up to 1,500 cc's. So it is important. It's like a self transfusion of blood that takes place. But so you have to be very careful that signs and symptoms, like you're thinking about pallor, shock, low blood pressures, all this will not take place or will not be seen until there is up to nearly 1,500 cc's of blood loss. So some of the other physiological changes that we have to keep in mind in pregnancy that can have an impact on resuscitation are related to maybe pulmonary. Here we find that there is an increased respiratory rate. There is an increase in oxygen consumption by up to 20%. The tidal volume increases and the minute ventilation also increases. And there is a decrease in your functional residual capacity, the arterial CO2, pressure of carbon dioxide, and serum bicarbonate. All these causes an impact on the mother in the form of decreasing the blood's buffering capacity, causing a rapid decrease in the arterial pressure of oxygen and making them more prone to hypoxia. And from hypoxia, they can go rapidly into anoxia, and then it may be difficult to bring them back from that anoxic state. There is a decrease in the buffering capacity, and there is a decrease in ventilatory capacity and compensated respiratory alkalosis. So keeping that in mind, we have to manipulate or direct our resuscitation to overcome these effects of pregnancy too. In the gastrointestinal system, you may see that there is a decrease in gastric motility, and the sphincter of the gastroesophageal sphincter tone can also be decreased, and they may make the patient more prone to aspiration. Intestinal compartmentalization. This is just the cephaloid movement of the gravid uterus upward, And what happens is it lies over the intestine and makes the uterus and the fetus more susceptible to penetrating injuries. But indirectly, it may protect the mother's intestine. Urinary changes that take place and renal changes that take place, there is increase in renal blood flow and increase in glomerular filtration rates, and causes an increase in the compensated respiratory alkalosis. But there is also a decrease in the BUN and creatinine. So once this happens, you may have a decrease in the blood and renal buffering capacity. And keep in mind, when you have a normal BUN and a normal creatinine level, it does not mean that it is normal for the pregnancy, because the physiological change is for it to be a little decreased. So when you see normal numbers, that might be misleading, but you should keep in mind that there is a progression to renal failure and be more vigilant. So back to basics again, guys. It is not anything elaborate, but I think we shouldn't forget what our basics are. And I know you all know what basic life support and the advanced life support comes in handy during our resuscitation period. So when you do your basic life support, your first response is to see whether the patient is responsive or not. And that can be done by the tapping or calling out her name and identifying if there is responsiveness. If there is no responsiveness, you're immediately activating the emergency response system, who apparently will come to your help with an AED too at the same time. Keep in mind that during basic life support or the CPR, the most important thing is circulation. And this is brought about by high quality compressions. That is the most important factor we have to focus on. Your compressions should be of high quality, which is defined as having the compressions go at 100 per minute. They should be to a depth of about 2 inches. They should be directed to the spine. So you cannot direct it to the spine if you are not supine. The patient has to be kept supine, maybe on a backboard, a wooden board, and the direction should be directly vertical down to the spine. But when all this happens, you are aware that the uterus is pressing on the aorta and the inferior vena cava. So it is very important that you displace the uterus with using one or both hands to the left and avoiding that compression over the aorta and the inferior vena cava. This is a new recommendation from the AHA too, that you don't use the old method of doing a wedge, a hip wedge, and you're tilting the patient onto the left lateral side, because this compromises your high quality compressions. So what you want to do here is put the patient supine, with one or two hands pull the uterus or push the uterus to the left, and make sure that you relieve the compression on the aorta and the inferior vena cava, and allow the sequestrated blood from the lower extremities, which is about 20%, get back into the system and improve its cardiac output. Next is your airway. The airway, we have to make sure that you open it. Either if it's not a trauma-involved patient, you can always do the head tilt and the chin lift and open out the airway. Breathing is also important here. You have to start ventilating at about 6 to 8 seconds every breath, and each breath should be about a second long. Also, in a pregnant woman, you have to improve, or you have to be very quick in advancing to use an advanced airway. You have to make sure that you can start off positive pressure ventilation as soon as possible. So at the same time, the defibrillator is coming in and you are trying to identify whether these rhythms are shockable. The two shockable rhythms we know of is ventricular fibrillation and pulseless ventricular tachycardia. And once you turn the AED on, it will start prompting to you to and direct you as to identifying the rhythm and whether it's a shockable rhythm. Two things that is current according to the 2020 AHA guidelines is, one, as soon as you start compressions, the high quality compressions, you have to start thinking about resuscitative hysterotomy. Resuscitative hysterotomy should be right in the forefront, right when you are starting compressions. You have to start getting prepared for your resuscitative hysterotomy, which will have to take place within 4 to 5 minutes of into the resuscitation mode. The other issue with the defibrillator or the AED is, in pregnancy, you have a dextrorotation of your heart. So in case you don't put the pads appropriately, you're not going to get a good rhythm, or it may take you into a misinterpretation of the rhythm. So what we do is we elevate the left breast and place the pad over the apex of the heart, so that that will give you a good reading of the rhythm that is to be identified. So then in advanced cardiac life support, you're continuing, you're just reinforcing your CABD again. And in this time, what happens is while the compressions are going, which is being done every 2 minutes, remember that there will be fatigue for the teammates, and you have to make sure that they rotate after every 2 minutes. And for the improvement of the circulation and for mainly to give drugs, you're starting to establish intravenous access above the diaphragm, and you're able to continue to monitor, identify, and monitor the rhythm and administer appropriate drugs. Now, the three main drugs that play an important role during your resuscitation is epinephrine, amiodarone, and lidocaine. Epinephrine, the dosing, as they say, is 1 milligram every 3 to 5 minutes. But the new recommendation is that you give 1 milligram every 4 minutes, so that you synchronize the giving of the drug with the compression cycles of 2 minutes of every 2 minutes. So we mentioned that you have to make sure that you do it, giving 1 milligram every 4 minutes. This is given IV, and it is usually given after 2 shocks. The next medication that the antiarrhythmics like the amiodarone and the lidocaine are given after the 3rd shock, and amiodarone is given in the form of 300 milligrams as your first dose and 150 milligrams as your second dose. The lidocaine, again, the dosing is about 1.5 to 1 to 1.5 milligrams per kg. That is the dose. Now, keep in mind that the airway, by now you would have done an advanced airway, and you're going to confirm the placement and secure the device. You're going to make sure that there is good ventilation and oxygenation that is identified. Adequate oxygenation can be identified with the use of the wave capnography that will give you an idea whether the breathing or the oxygenation is appropriate. You have to keep in mind your differential diagnosis. It does not mean that once a patient or a pregnant woman goes into cardiac collapse, that it is all related to the big guns of amniotic fluid embolism or pre-eclampsia or PPH. It could be simple things like if she's a pre-eclamptic patient, she may be on magnesium, it may be related to magnesium toxicity, and you may have to withdraw the magnesium and give the antidotes of either calcium gluconate if you have that, or calcium chloride if that's in the cart. Otherwise, same thing with any other issues of the differential diagnosis, the causes. It could be simple hypovolemia or hypoxia or any anesthetic compilation. So don't forget to keep the simple causes that can be easily corrected in mind, and stay calm and continue working as a team member. Also, it is important when you start your BLS and your systemic and their response team has come in, assign somebody to keep time. It is very important that timing is kept from the very beginning, and they call out the intervals at 30 seconds. It used to be 1 minute apart. Now they have converted it into 30 seconds when you will call out the time frame, because it is very important about getting your resuscitative hysterotomy within the first 4 to 5 minutes. So in summary, the cardiac arrest in pregnancy, you are going to identify for responsiveness. You're going to activate the cardiac arrest team. You're going to prepare for possible resuscitative hysterotomy. Again, assign team members to record events and announce how much time has elapsed. In the past, it used to be every minute, and now it's every 30 seconds. Performing cardiopulmonary resuscitation, that is a CPR, but not using your hip wedge, which was done in the past. No longer carried out. Now it is uterine displacement manually to the left. Instead of keeping the woman supine position, displace the uterus with the hands while performing chest compressions. Ensure that you have high quality chest compressions and it is directed towards the spine. Chest compressions, when you are doing chest compressions, when the woman is in the supine position, they are 80% stronger and much more effective than when you do it in the left lateral tilt position. And also manual displacement of the uterus also improves the blood getting back into the systemic circulation. All 20% or 25% of the blood which was sequestrated in the lower extremities are back into the systemic circulation and improving your cardiac output. So this is an idea of how you do your resuscitation and uterine displacement. If it is just above the umbilicus, a gravid uterus with the just viable for viable at 20 weeks, then you may just need one hand, but otherwise you will use two hands to move the uterus, pull or push the uterus towards the left and continue with your chest compressions. So maternal cardiac arrest, what happens? Sometimes you may be called while the patient is in labor and delivery and has all the monitors still on her. Now, the recommendation in the past, we used to remove the fetal and uterine monitors and then start thinking about giving defibrillation or using giving the shock. But now, if it saves time, ignore the monitors. You don't have to worry about the monitors. The only reason why we were removing the monitors was because it might not work or function well after a shock has been given. So it is not important. If you don't want to compromise the time. If you don't, you can leave the monitors and continue with your defibrillation, or you can remove them if you have the time. Using 100% oxygen is also important and once you have secured the advanced airway. And this is given by giving it as 15 ml of oxygen every minute, either by using a bag mask or through your endotracheal tube. Using a typical advanced life support drugs and shock are usually carried out. There is no change in the strength of the shock that is given in pregnancy and in a non-pregnant. You start off with 120 to 200 joules of a biphasic current and keep increasing if it doesn't respond to that shock. If there is no return of spontaneous circulation after 4 minutes of resuscitation, remember you have to immediately consider delivering this baby by resuscitative hysterotomy or otherwise a cesarean delivery. You can plan to start doing the hysterotomy by 4 minutes, and by 5 minutes you should be able to get that baby out. And not to worry, it's a bloodless field. The mother is in a collapse mode. You're not going to have any bleeding or anything happening there, and this can be done pretty fast. So remember the 4-minute rule. You need the fetus of an apneic or an asystolic mother may have only the oxygen reserve for about 2 minutes. So after 4 minutes without return of spontaneous maternal circulation, resuscitative hysterotomy has to be considered. You aim to perform this within 5 minutes. And sometimes there has been a few studies that showed that even after 20 to 25 minutes, they did deliver babies which had about only 50% injury-free. They were about 50% injury-free. But if you carry out this resuscitative hysterotomy within the first 4 to 5 minutes, you have a 90% with no neurological compromise to the fetus. So it is very important that we do it within the first 5 minutes. So indications, you know that it is a viable gestation. The pregnancy should be equal or over 20 weeks, which means over the umbilicus. The woman does not benefit or has not responded to the resuscitation for the last 4 minutes, and you may require appropriate facilities and skilled personnel available to perform this procedure and care for the mother and the newborn. It doesn't mean that everybody, you at least need somebody with a surgical skill to do this, and you don't expect a nurse or one of the nurse assistants to be able to do this, resuscitative hysterotomy.
Doctor, you are Dr. Thomas, you're muted. Dr. Thomas, you're muted. Dr. Thomas, can you hear me? Yeah, you're muted. Dr. Thomas, you're muted.
Here you go.
Okay, sorry.
Sorry. Okay,
That's
I
all right.
don't know how that happened. Anyway, maternal complications after resuscitation. Now, you would have done a good job resuscitating the patient, but you have to be aware, if you have done good compressions, you are not going to escape having a couple of rib fractures. There might be a tendency to have rib fractures, but being pregnant, you also have to identify some other iatrogenic injuries that can take place, which could be liver lacerations or a pneumothorax. In women with preeclampsia and thrombocytopenia, we need to even be worried about any form of internal bleeding and hematomas around the liver or in the liver. I'm not able to, yeah. Trauma in pregnancy. Now that we've completed something on the resuscitation efforts and resuscitative hysterotomy, let's try and consider issues of trauma in pregnancy. This, we know that it complicates about 6 to 7% of all pregnancies. It is one of the leading non-obstetrical causes of death in women who are pregnant. 9 out of 10 traumatic injuries occurring during pregnancy are related to minor trauma, and in those in that category, about 60 to 70% of fetal loss also results from minor trauma. So the key take-home message here is, do not underestimate when a patient comes in stating that she had a mild fall or just slipped and fell or banged her abdomen somewhere. Any of this minor trauma can compromise, and you may have fetal loss subsequent to this. So what are the incidents of trauma in pregnancy? You can get the causes related to trauma. The most common and the most common cause is the motor vehicle accidents. Falls come next at 25%, assaults at 16%. You may have gunshot wounds, 4%, and suicide and burns. But more important is to identify intimate partner violence. This is on the rise, and I think we as patients, physicians who see the patients antenatally for a good number of visits should be aware and should be vigilant about intimate partner violence. So in motor vehicle accidents, approximately 3% of pregnant women are involved in motor vehicle accidents. It accounts for about 50% of all trauma in pregnancy. And this can be precipitated because patients are unaware of the importance of seat belts. So during our antenatal visits, we should be educating our patients on how to wear or place the seat belts. We know that it decreases maternal deaths and severe injury by about half. And it is important that we focus on this on probably every other antenatal visit, just try to remind them about it. So the way of using the seat belt, the positioning is that the lap belt is placed under the gravid uterus, below the gravid abdomen, and across the anterior superior iliac spines, while the shoulder belt goes across the breasts. Airbags, again, are a little intimidating to the patient, especially to a pregnant patient, and they think that it might cause harm to the mother or to the fetus. But it is not associated with any increased maternal or fetal morbidity and mortality. And we have to, again, reinforce this to the patients when they come antenatally. So intimate partner violence. All pregnant women should be screened, and this can be done by your nurse or by yourself while you're in their antenatal visits. It is important to identify patients and because you can sort of send them for counseling and referral early in the pregnancy itself. Battering may increase during pregnancy, and the abdomen is pretty much the target very often. So what are the indicators or the subtle things that we have to keep in mind for partner violation? Remember, injuries are always, when the patient comes and describes to you the different injuries that are taking place, those injuries are inconsistent with the stated history. diminished self-image. You may see signs of depression, suicide attempts, maybe may come out historically. She is attempting to commit suicide a couple of times. There might be evidence of self-abuse. There is also trips. She does frequent emergency department or office visits. These are all red flags that we need to keep in mind, that she is trying to come out and tell us something. Symptoms suggestive of substance abuse may be identified. Self-blame for injuries may also be there. Partner, sometimes when these people come with their partners, the partner insists on being present for every interview and examination and tries to take control of the situation. Even when you identify this and want to have words with the patient privately, you will identify this a very dominating figure of this partner, and we have to be very vigilant about partner violence at that time. So what are the physiological changes of pregnancy that can impact on trauma in pregnancy? We know that the amniotic fluid in the second trimester is in abundance, and this will protect the fetus. But in the third trimester, we may have a decrease in the volume, and it has a decrease in the protection of the fetus and of the mother. A lot of penetrating injuries and stab wounds can take place because there is easy access. The uterine wall also is thinned out in the third trimester and more susceptible to penetrating injuries and to rupture. The placenta, because of the forces of acceleration and deceleration, it is a shearing force that may lead to abruption. So when you look at a patient, a pregnant patient with trauma, you're not forgetting your basics. You know, when surgical people with trauma, they will always go through your primary maternal survey, your secondary maternal survey, and a fetal survey. So what do we do in our primary maternal survey? You are, again, looking for responsiveness. And if they are responsive, you're looking at whether they are oxygenating or breathing well. So you need to make sure that you keep a patent airway. If she is unconscious, you have to make sure that you do an early intubation. The key is to have adequate ventilation and oxygen. Effective circulatory volume. Again, you would have done, if she is awake and breathing and has a pulse, you're going a step further and doing the fluid support. Your IV lines are being started well above the diaphragm, and the blood replacement is also taking place. So when you have, you're also keeping in mind the 25% of blood that is sequestrated in the lower extremities. So you're decreasing that uterine compression of the vena cava by manually displacing the uterus. And if the patient comes in with a spine injury and she's on a cervical collar, then you are not going to try and keep them supine. You're going to try and do the log roll to the left and make sure that there is no compromise to the 20% or 25% from the lower extremities. You have to add baseline lab tests are done, but along with that, make sure you include fibrinogen, because we know that in pregnancy, fibrinogen levels are on the rise. But when you identify the fibrinogen level coming to normal or dropping, you know that there may be impending DIC, and you have to be a little bit more vigilant on what may happen to the patient. Now, coming to secondary maternal and primary fetal survey. So in your secondary maternal survey, it's all the diagnostic modalities that are being put to use. Do not hesitate in ordering or getting an X-ray if that is required to identify causes. People might say that it may have an impact on the fetus, but the pros and cons and the advantage of getting the X-ray for the mother is way oversees or supersedes that of taking care of the fetus. You may be able to protect the fetus if you want, but if an X-ray is indicated, please, that has to be ordered. You also do the FAST examination, that is using ultrasonography to identify any anatomical damage to the internal organs or collection of peritoneal fluids within. Diagnostic peritoneal lavage is also carried out, wherein you make sure that the catheter is above the umbilicus. Maternal abdominal examination. Now you have to identify if there's any signs of abruption. You assess the fundal height. You identify whether there is any signs of abruption with uterine tenderness or persistent contraction, or is there evidence of uterine rupture. Make sure that you monitor the uterine activity. You also, if it is a gravid uterus and it is more towards term, you have to identify whether there is any onset of labor, but only done after you have ruled out a previa. You can assess for any effacement or dilatation, but also at the same time, you can assess for bimanual vaginal examination and if the membranes are intact. Also, you assess for fetal heart rate and fetal movements. You are still continuing to monitor the cardiac output. You can do a central venous line and make sure that your pressures are all well recorded. Baseline lab tests again include serum bicarbonate, RH and KB, coagulation factors, and assess whether this patient may need to be admitted or not. So minor trauma evaluation. What are we concerned about and what should we be doing? As we said, once we've completed the primary maternal and fetal survey and having done the labs, which are like the type and screen, the complete blood count, KB test and coagulation, you can, if a patient is stabilizing, you can consider an OB ultrasound also. And make sure that you monitor for contractions by putting her on the monitor if the pregnancy is over 20 weeks gestation. So in minor trauma, you're monitoring what does it entail. If it is minor trauma, you can observe. All these patients have to be observed, whether it is minor or very significant trauma. With the minor trauma, you have to observe and monitor them with the continuous cardiotocography for at least a minimum of 6 hours. And then you may discharge them after 4 to 6 hours if the monitoring shows less than 6 contractions per hour and there is no risk factors. Now, we haven't spoken about the risk factors with minor trauma. So what are these risk factors that we have to keep in mind? The risk factors when you have a patient with minor trauma include an injury severity score of more than 9, maternal heart rate, which may be over 110 beats per minute, evidence of placental abruption in the form of vaginal bleeding, uterine tenderness, abdominal pain, or tachysystole, baseline fetal heart rate, which could be over 160 beats per minute or less than 110 beats per minute, ejection, if there is a history of the patient being ejected from a motor vehicle, or if there is a history of the patient being involved in a motorcycle accident or a pedestrian collision. All these factors, if you have any one of these, the patient is committed to staying for a minimum of at least 24 hours. So continue to observe for a minimum of 24 hours if those items, if those risk factors are present, or if you have uterine contractions which are more than 6 an hour, if you have a category 2 or 3 tracing, if you have vaginal bleeding, or if you have significant uterine tenderness, or a serious maternal injury, or if you have rupture of membranes. If any of this or of the risk factors are present, she is committed to staying in the hospital for the next 24 hours to be monitored. And the discharge will occur only when there is resolution of contractions. And she is one who has intact membranes. She has no uterine tenderness. There is no vaginal bleeding. And remember, all patients who are Rh negative has to receive ROGAM before they are discharged from the hospital. So amniotic fluid embolism, this is also another big one influencing cardiac collapse or causing cardiac collapse. And we have to be very vigilant and very quick in our diagnosis and managing these people with amniotic fluid embolism. It occurs in 1 in 15,000 pregnancies in North America. Maternal mortality rates historically was high at 85%, but has come down to about 13 to 30% in the States because of good management in the critical care units. I think in Europe, it's about 10 to 44% that it has come down. They don't know the etiology of amniotic fluid embolism. They know it's not a true embolism. It could be an anaphylactoid reaction of the particles of and the amniotic fluid antigen in the maternal circulation, or it could be stimulation of the complement cascade that is causing issues related to anaphylaxis. Risk factors for this are mainly multiparity, tumultuous labor, abruption, intrauterine fetal demise, or oxytocin-induced uterine tachysystole. So clinical presentation of amniotic fluid embolism, it can come in with very mild symptoms of just restlessness and nausea, but rapidly proceed to respiratory distress, cyanosis, seizures, coma, and even death. It is a situation where you may have an unexpected cardiovascular collapse taking place, and you will see disseminated intravascular coagulopathy. The progression, keep in mind, guys, the progression is very rapid. And the way you can identify or come to a diagnosis is primarily by a clinical approach, clinically diagnosis based on symptoms, or you may make the diagnosis post-mortem. Rapid onset coagulopathy can distinguish this from other etiologies, and that is why the importance of that fibrinogen level and keeping intravascular coagulopathy in the back of your mind. The differential diagnosis for this, again, is massive pulmonary embolism, bilateral pneumothorax, myocardial infarction, uterine rupture or inversion, could be from septic shock or eclampsia itself. So again, the stat labs that we order as for routine emergencies are your CBC, your ABG, your electrolytes, BUN and creatinine, your glucose, your coagulation study is very important, cardiac enzymes, all tests to rule out some of the differential diagnoses in the etiology. Your blood urea, creatinine, urine protein, lactate, liver functions, and uric acid. So in summary, physiological changes in pregnancy can affect trauma and cardiac arrest. Your basic life support, ACLS, and trauma care should be appropriately modified in women who are pregnant. Resuscitative hysterectomy should be considered after 4 minutes in women who are pregnant and who do not respond to the resuscitative measures. Amniotic fluid embolism is a rare but important condition that may cause cardiovascular collapse. So I think, folks, even though we have discussed so much about these separate etiological factors like pre-eclampsia, postpartum hemorrhage, and the other things, your basic requirement of teamwork, of standardization of care, of using the mnemonics, trying to do drills in your office, in your hospitals, regularly doing this to improve and make everybody in a maternity care unit aware of teamwork and what to do. Once you're all on the same page, or standardizing the care, the team approach and the response to an emergency would be much smoother and more successful, and we will be able to reduce our maternal mortality and morbidity. Thank you, everybody. This has been a pleasure and an honor to be in such an esteemed speaker panel. And I appreciate once again Dr. Mazer, Dr. Mohammed Madani, and the Jordanian Society for giving me this opportunity. Thank you
very much. Thank you for this excellent presentation covering maternal resuscitation and trauma and pregnancy. Very, very important subject. And that's what we're trying to do in Jordan, to reduce the maternal mortality. It was excellent. So I would like to thank you. Now, and I'm pleased to say that we at the Royal Medical Services and King Hussein Medical Center, we've been accredited to do ALSO courses, and we have done few ALSO and PALSO courses at the Royal Medical Services, and I will encourage anybody who wants to attend to contact me or the society so we can arrange it for him or for her. Now, I had a question earlier on, a doctor from Oman asking that he's been trying to do also course in Oman. Do you have any idea if there is any contact with the Omani society regarding also courses?
You know, I think they used to have this in the past. When I was in Dubai and working with Dr. Rabia Nohad, and we were attempting to get this across to the neighboring countries too. And we did not have a contact, or she attempted to get a contact person there, and they didn't know who was in charge presently. So now that we have a person who is interested, he just has to either, he can email me or we can call the academy, and we will be able to try and establish that. There is a process that takes place in getting the license. But if you have a couple of advisory faculties we can, come over and establish the course there, or even people who are nearby. You can ask you guys in Jordan can help send some of the faculty out there to run a course, or they can come and you can get them certified as instructors and as course directors down the road. Yes, you should be able to do it, to answer your question. And we will be very happy to help you. I have even carried out in this COVID situation a lot of virtual classes and done hands-on virtually, to get them licensed and to get courses conducted. So please reach out to the academy. We will make sure that you do it, and we will make sure that also is going to come to Oman.
Yeah, and we're quite happy to help in any way we can, the faculty at the Royal Medical Services. Now, in America, I mean, also, is it compulsory for trainees in Ops and Ghani, or is it optional? Because I think the courses are excellent, and I believe all trainees should do also courses, or the equivalent of also in other countries as well. So I would like to have your answer on that and your views on also training for residents in Ops, OBYGN.
I will give you a little bit of my own experience with the also courses. I've been in Chicago in the family medicine residency program, and we made it mandatory for all residents interns to take the also course when they enter into the residency. The obstetricians reached out to me and asked whether they could send their residents to do this as a orientation course, and you would be surprised how happy those residents were, because they felt so much more confident going to labor and delivery, having known and having some sort of an idea of how to handle the emergencies. This can be done in Chicago. I used to have a few of the obstetric residents also come and do the course with the family medicine residents and with the nurses and with the senior obstetricians. So everybody is learning on the same platform. That takes care of some of the friction that might happen with seniority and juniors and others too. So I think it is an excellent one. And only in America, it is with the primary cares and the midwives. All the also courses that I've conducted around the world are all with obstetricians. India does only obstetricians do OB. Nobody else. Primary care doesn't do OB there. So all my also courses, which I've done more than about 50 courses in India, are all focused on obstetricians and who are in training, and also from the professor to the intern. They're all there participating in this. So it is easy. You may have to apply, but if you can make it mandatory for the obstetric residency programs too, that is good. As of now, it is only an elective. They can take it. It all depends on the program director and how they want their residents to be trained. Sometimes they think, oh, you're doing it from an American Academy of Family Physicians and not run by obstetricians. But all the material is contributed by all of them. We have obstetricians also who contribute to this, the syllabus of the also course. And I think it is a great orientation. It is a great way to get the older obstetricians updated on what's current and what's to make them feel more comfortable, and standardizing care and making everybody team leaders. Nobody is a teammate, but a team leader. They need to be able to do this.
Yes, I completely agree. I think I'll finish the, we'll finish, unless Dr. Mazen, do you have any questions?
Yeah,
or you want
no, just a little comment.
Go ahead.
Thank you very much, Dr. Thomas. One important issue is that everyone should train or take a course in also, because what happens in most of the countries, and even in Jordan, in most hospitals, if there is cardiopulmonary collapse, they call the CPR team. CPR team do nothing, or know nothing about the pregnant woman physiology and anatomy. So I have seen cases where they start looking around them. They don't know what to do. But I think if there is people who are trained in maternal resuscitation and have done the course in also, I think it is very important. Thank you, Maher, because you as a you are a chairman of a big department in the country. You should encourage people to do it. Residents not only in the military hospitals, but you should help others or those who went to states and did the course. They should, when they come back, do courses here for residents in all hospitals, because you know the cardiopulmonary collapse, or it may happen anywhere. It may happen in the market. It may happen in a smaller hospital and in primary hospital. So we need a lot of staff and all our residents to be trained in resuscitation. And thanks very much, Professor Sanjay, for your lecture. I know we gave you very short time, but I think your experience allowed you to prepare such a nice lecture. Also, at the end, I
think Dr. Mazen, I think Dr. Thomas wants to say a final word. Go ahead, please.
You know, just a quick word, Dr. Meza. We also offer this to the emergency room residents, you know, because when they have a patient comes in with pre-eclampsia, they don't know how to handle this. So even emergency room residents get a lot of benefit out of this. So it is a combined effect with family medicine or OB residents and emergency room residents.
So it should be multidisciplinary, exactly. So at the end, I would like to thank you again and thank Professor Laura McGee, Muayyad Al-Azam, Dr. Muhammad, and Dr. Abdullah Adra, because for this excellent webinar, I think everyone has benefited from your talks. And we are looking for the next meeting. I think, Maher, can you give us another reminder for the next meeting, which you are going to chair? Maher.
Yeah, it is in 2 weeks' time on the 13th of August. It's a Friday, again from 7 till 9 Jordan local time. We have 4 excellent speakers from different countries. We have a speaker from Egypt, we have a speaker from Tunisia, we have a speaker from Lebanon, and we have I'm going to talk about maternal mortality in Jordan. So we're going to discuss and look at maternal mortality in our region and look at different figures, statistics, and how can we improve things in the region. So I hope that all the participants will join us in 2 weeks' time. And I would like to thank all the speakers and the panelists for their excellent effort. Thank you.
And many thanks for the...
One question?
Yeah, Dr. Thomas, go ahead.
Can you, by any chance, give me the contact person for in Oman, or give him my address, my email, sajnithomas@gmail.com?
I have already sent her or him my email now. So if they contact me, I'll pass it to you, Dr. Thomas. No worries.
Thank you.
You're welcome.
Thank you. Another thanks for the drug company, Dawliya International Pharmaceutical, for supporting this activity. Thank you again.
Thank you.
Thanks.
Thank you very much.
Thank you. See you.
Bye-bye.
Bye.